Hello,
we can start the meeting.
Please start the meeting.
Yeah, good morning, everyone. Is Dr. Mohit here?
Yes, good morning, doctor. I'm there.
Yeah. So let's start the meeting.
Yes.
Mohit, your talk is on physiology of endometrial development and implantation. This voice is echoing. I don't know why. Varun? Is Varun here?
Yeah, I'm here.
Yeah, Varun, there is something wrong with the voice.
Yeah.
Okay, Mohit, the time for the talk is 12 minutes and 3 minutes for any question and answers.
Right.
Yeah, I guess there's again an issue getting the voice.
Yeah, Mohit's slide is also not very clear.
Yeah. Can we start screen sharing also for me?
Okay, Mohit, you can give a short introduction of yours and start with your talk, please.
Thank you, Dr. Poonam. I'm Dr. Mohit Sarogi from Mumbai. Basically, I have a chain of IVF centers in Mumbai by the name of Iris IVF Center. And at the onset, I would like to thank Dr. Poonam, the respected chairpersons, and the organizing committee for inviting me here. I will be speaking on. Just a minute. Is my screen sharing on right now? Can you see?
Yeah.
Yes.
All right. So let me start with my talk. So my talk is going to be on physiology of endometrium, endometrial development and implantation, which is going back to the basics. So we all know that in a regular 28-day ovulatory cycle, a number of changes are seen at the level of the ovary, in the uterus, and in the body hormones. What starts from the primordial follicles eventually moves on to the preantral, the antral follicles, the secondary follicles. And then once ovulation occurs, it forms a corpus luteum, and then the corpus albicans. Now, in this entire regular 28-day cycle, there is an array of changes which take place in the hormones. So, there is a baseline drop in all the FSH, LH, estrogen, and progesterone. And this is followed by a gradual rise in the estrogen, followed by progesterone, a peak, and then a rapid fall. And this is what is responsible for all the changes which take place in the endometrium. And this is what regulates implantation. So let's look at it more in detail. Now, to understand the physiology of endometrial development, we need to first understand what the endometrium looks like. So morphologically, the endometrium is divided into two parts. The upper 2/3 is known as the functionalis layer, and the lower 1/3 is known as the basalis layer. The basalis layer is constant, it never sheds, but the functionalis layer undergoes periodic shedding. Now, the purpose of the functionalis layer is to prepare for the implantation of the blastocyst. Hence, it undergoes cyclical proliferation, secretion, and then degeneration as the menstrual cycle advances. The purpose of the basalis layer is regeneration of the functionalis layer once menstruation has occurred. Now, the sequence of endometrial changes associated with an ovulatory cycle has been carefully studied and classified. Over the month, a number of anatomical and functional changes occur in the various components of the endometrium, that is the glandular, stromal, and vascular components. And based on this, we can classify it into 5 main phases. One, we have the menstrual endometrium, then the proliferative phase, the secretory phase, the phase for implantation, and lastly, the phase of endometrial breakdown. Now, if you look at the menstrual endometrium, the timing is from day 0 to day 4 of the cycle. At this point of time, the FSH, LH, estrogen, and progesterone levels in the circulation are low. The endometrial thickness is only about 0.5 mm, and that is the basalis layer mainly. At this stage, the composition of the endometrium is the basalis is intact. Most of the spongiosome is shed off, except for a very tiny portion. In the spongiosome layer, you will see fragmentation of degenerated glands, stroma, broken vessels, and there's a lot of infiltration of stroma with white blood cells and RBCs. However, even before the degeneration and shedding is complete, that is around day 2 or day 3 of the menses, A lot of mitotic activity begins in the epithelial layer, in the shed endometrium. This is at the level of the broken glands, and this epithelialization spreads horizontally and rapidly covers the endometrial cavity. So even by day 4, more than 2/3 of the endometrial cavity is covered with new epithelium. By day 5, almost the entire cavity is covered with the new endometrium. Now, once the menstrual phase is complete, this goes on to eventually the proliferative endometrial phase. Now, this is from day 4 to day 14 of the menstrual cycle. Here you've got the early proliferative phase, which is around day 4 to day 8, and then the late proliferative phase, which is around day 8 to day 14. Here, there's a rise in the FSH levels, which leads to development of the dominant follicle. As a result, the serum estrogen level rises steadily, and the rising estrogen levels are responsible for the endometrial changes. As we all know, the ET at this phase, in the early phase, is around 3 to 5 millimeters, and in the later phase, it can be about 8 to 10 millimeters as well. Microscopically, the glands start undergoing proliferation at this stage, and at this point, they're narrow and tubular and lined by columnar epithelium. As the mitosis advances, it becomes pseudostratified, and around the 8th day, the epithelial cells start developing cilia, and they become ciliated microvillus cells. If you look at the blood vessels, even the blood vessels start proliferating at this stage, but at this point, they're not coiled. They're straight, unbranched, and they grow inside the stroma, the endometrial stroma. If you look at the stroma, in the early proliferative phase, the stroma shows mild edema. However, by late proliferative phase, it has a loose syncytial-like character with spiral vessels coursing through it, and lymphocytes and macrophages scattered throughout. Then is the third phase. This is the secretory phase. This is seen from day 14 of the cycle onwards. Here, ovulation has taken place. So here, the rising estrogen levels in the follicular phase leads to an LH surge. This leads to the ovulation. And once a corpus luteum has been formed, the corpus luteum then secretes both estrogen and progesterone, but mainly predominantly progesterone. This progesterone is responsible for the secretory changes. Now, progesterone has an inherent character of being anti-estrogenic. It downregulates the estrogen receptors as well as induces rapid metabolism of estrogen. As a result, due to the decrease in estrogen action, the proliferation decreases. The thickness may mildly decrease also. However, the growth of the glands and the blood vessels continue. So because they have to grow in a limited, tight, compact area, they acquire a spiral and highly coiled structure. So in this phase, if you look microscopically, you'll see the glands and spiral vessels are extremely tortuous. Also, because it is a secretory phase, you have secretory vacuoles which start appearing within the epithelial cells. This occurs around 17th day of the cycle. So subnuclear intracytoplasmic glycogen vacuoles start appearing. And the characteristic is they gradually migrate to the luminal surface over the next 7 days, that is around day 22 or 23 of the cycle. And then this is responsible for the endometrial secretions. These vacuoles eventually help in the secretion, active secretion of glycoproteins and peptides into the cavity. The peak secretory activity is seen 7 days after the LH surge, coinciding with the time of blastocyst implantation. Now, if you look at the implantation endometrium, this is found around the 21st day of the cycle. The endometrium at this stage is divided into 3 zones. The lower 1/4 is the basalis layer we know about. The middle 50% is known as stratum spongiosum because of its sponge-like characteristic. Sorry. Yes. Now, at this stage, it is composed of edematous stroma with highly coiled vessels and glands. And the upper 1/4 is called the stratum compactum because of its compact structure. Here in the stromal cells become enlarged, polyhedral, and they interlock. It's almost like a brickwork arrangement. Hence, because of its compact structure, it's called the stratum compactum. The neck of glands and blood vessels traverse through these stromal cells and are less prominent. A unique feature of this phase is the presence of something known as K cells, which are seen around day 22 of the cycle. The last phase of the endometrium is the phase of endometrial breakdown. If pregnancy fails to occur, the LH levels start falling, and this in turn leads to fall in the estrogen and progesterone levels. This in turn leads to shedding of the endometrium. So what happens is the progesterone has a stabilizing effect. The secretory endometrium is rich in lysosomes, which in turn contain proteolytic enzymes. And the only thing that prevents disintegration of these lysosomes is progesterone. It has a membrane stabilizing effect. So once progesterone levels fall, the lysosomes disintegrate, proteolytic enzymes get secreted, and this leads to tissue necrosis, vascular thrombosis, and eventually shedding of the endometrium. So this in turn summarizes the entire endometrial physiology. Now, if you have to understand implantation, the physiology of implantation, our understanding of the implantation process has undergone a major shift in the last few years. Now we know that the phenomenon of implantation is dependent on a crosstalk between a good euploid blastocyst embryo and a good receptive endometrium. Now, the endometrial receptivity is maximum 7 to 8 days post ovulation. The window period for implantation is a short span ranging from 2 to 4 days and is known as the window of implantation. Now, let's understand how the window of implantation works. Now, one of the popular theories is the Pinobot Theory. Now, progesterone induces the formation of pinopoids on the endometrial epithelium. So what happens is the epithelial cells lose their polarity and microvilli due to the action of progesterone. And this occurs due to downregulation of what is known as cell-to-cell adhesion molecules. Now, because of downregulation of this, the embryo can implant upon the endometrium. So what happens is the cells lose their polarity, their microvilli, and then they develop smooth protrusions on their apical surface and form what is known as pinopods. The most important feature of the pinopods is loss of a particular glycoprotein known as cell surface glycoprotein mucin, which inhibits cell-to-cell adhesion during the window of implantation. So to summarize, progesterone downregulates this particular glycoprotein, and in this in turn facilitates the adhesion process or the adhesive process between the blastocyst and the endometrium. Now, before implantation occurs, the blastocyst remains in the endometrial cavity and in the uterine secretions for 1 to 3 days. Then what we know as hatching occurs. That means the zona pellucida sheds and the the blastocyst hatches out from the zona. The hatched blastocyst then undergoes structural changes such that a more irregular surface with more microvilli is observed, and this eventually adheres to the endometrium. The blastocyst then differentiates into an inner cell mass, which eventually forms the embryo, and the trophoectoderm, which forms the placenta. The usual site of implantation in the uterus is in the upper posterior wall in the mid-sagittal plane. There are 3 main stages of implantation, namely apposition, adhesion, and invasion in the same sequence. So apposition is where the blastocyst contacts the implantation site of the endometrium. Adhesion is where the trophoblast cells of the blastocyst attach to the receptive endometrial epithelium. And invasion is where the trophoblastic cells invade the endometrium cells, invade the basement membrane, and eventually invade the endometrial stroma, resulting in the formation of the placenta. Let's look at each of these things a little bit more in detail. So apposition, this occurs 2 to 4 days after the morula enters the uterine cavity.
1 minute left, Mohit.
Ma'am, last slide, I'll finish.
Okay.
It is preceded by hatching of blastocyst, followed by differentiation into the inner cell mass and trophoectoderm. At the same time, stromal cells in the endometrium surrounding the blastocyst form what are known as decidual cells. It is a pro-inflammatory condition and associated with elevation of PGE2 and other COX-derived cytokines. LIF, that is leukemia inhibitory factor, CSF1 and interleukin-1 are important mediators regulating apposition. In adhesion, there is a bridge formation or linking between adhesion molecules and ligands. So adhesion molecules are present on the surface of the blastocyst. These are integrins, selectins, and trophonins. And they in turn adhere to ligands, which are molecules present in the connective tissue of the endometrium, namely laminin and fibronectin. So these adhere together, and this results in implantation. And lastly, let's look at invasion and placentation. So the trophoectoderm by this stage has differentiated into what is known as the cytotrophoblast and the syncytotrophoblast. The cytotrophoblast secretes the HCG. This in turn maintains the corpus luteum and allows for progesterone secretion. It is the syncytotrophoblast which secretes proteolytic enzymes which help the blastocyst invade into the endometrium. Eventually, the trophoblastic cells destroy the walls of the maternal spiral arteries, converting them from muscular high resistance vessels into flaccid sinusoidal sacs. The aim of this is to convert the high resistance circulation into a low resistance, high capacitance circulation, and this will maintain adequate blood flow between the fetus and the mother. The extent of trophoblastic invasion later determines the placental sufficiency and insufficiency as pregnancy advances. So, to conclude, implantation occurs due to a complex dialogue between a receptive uterus and a competent blastocyst. Implantation failure is a major rate limiting step in the success rates of IVF today. A complete understanding of the molecular pathway of implantation is yet to be achieved. Once we are able to do so, we will definitely be able to improve the diagnosis and treatment of infertility. And sensitive and non-invasive methods to detect embryo quality and endometrial receptivity are the need of the hour. So with that, I'd like to thank you for a very patient hearing.
Thank you, Dr. Mohit.
Thank you.
Yeah, Varun, hi.
Hello.
Yes, Neha.
No, I'm Dr. Suparna Banerjee.
Suparna. Okay, Suparna, you continue, please.
Okay, so Mohit, it was an excellent presentation. So we need to know our basic to improve our complex treatment. I think we are going to discuss question answer session later after we finish all 4 talks.
Yes, ma'am.
Dr. Mohit,
Okay.
can you stop sharing your screen?
Yeah, I will just stop doing that. Just a minute. Huh? Yeah, I have stopped, I think.
Okay. So our next talk of the morning is how to manage a refractory endometrium. So it will be our next speaker is none other than Dr. Nalini Mahajan. So I think Dr. Mahajan needs no introduction, but with her CV, I will highlight few things. She is director of Mother and Child Hospital, Delhi, scientific director of Fertility Clinics, Navjivan Vihar, founder president of Fertility Preservation Society India, president of Asian Society of Fertility Preservation, board member International Society of Fertility Preservation, patron and chairperson Public Awareness Committee PCOS Society, past president of IFS, chief editor of Onco-Fertility Journal. Is Dr. Mahajan here? Hello.
She has a pre-recorded video session.
Okay. So we can start the slide sharing.
Good morning, dear friends. At the very outset, I'd like to thank Dr. Gautam for inviting me to this meeting. I have been asked to speak on managing refractory endometrium, and we know how difficult a topic this is. And I hope that in the 15 minutes that I have, I will just try to highlight some of the important new developments. For a functionally competent endometrium is essential for implantation, and currently the clinical tools that we have for endometrial assessment is only the ultrasound, and we look at endometrial thickness, endometrial character, and endometrial vascularity. An ideal endometrium is supposed to be 7 millimeters or more on the day of LH surge with a triple line pattern, and what this suggests is that the endometrium has had sufficient estrogen exposure with estrogen receptors, which are now going to be able to take on the action of progesterone and allow for implantational changes to occur. So endometrium below 7, or some people say 6 millimeters, is known as thin or refractory endometrium, and we see it fairly often in ovarian induction cycles as well as in IVF, where the incidence is supposed to be about 1 to 2.5%. And the reason why we are worried about this is because it reduces implantation rates and increases the abortion rate. And so we need to find out, is there a minimal endometrial thickness which is necessary for implantation? What are the causes of thin endometrium, and how can we improve it? The commonest cause in India, of course, in terms of pathology, is genital tuberculosis. We have a large segment which is iatrogenic. That means we create the problem either by giving drugs such as clomiphene and even letrozole, or the ones where estrogen metabolism is increased by doing very thorough curatages and ruining the basal layer of the endometrium, or then in cancer treatment through radiotherapy. There are congenital causes and vascular and idiopathic, which is, of course, is the most difficult of all. So in this study, which was a systemic review and meta-analysis of almost 17 RCTs and about almost 4,000 women, it was seen that the endometrial thickness is not at all a predictor for success in IUI with ovarian stimulation. And once again, this confirmed that clomiphene was the biggest problem creator in terms of the endometrial thickness, followed by letrozole. So these are the two drugs, if we find a thin endometrium, we need to worry about. When it came to IVF, this large study, this is almost about 40,000 embryos transferred, showed that in fresh transfers, if the endometrium is less than 8 millimeters, and in frozen transfers, if the endometrium is less than 7 millimeters, then there is a decline in clinical birth rate and live birth rate. And in fresh embryo transfers, low ET below 8 also suggests a higher miscarriage rate. Having said that, what we find are the guidelines. What the guidelines suggest is if you are having this thin endometrium of less than 8 for fresh and less than 7 for FET, then we must counsel the patient, and in fresh we can offer them an elective frozen cycle, and in the FETs we cancel the cycle and try to start again to try and get a better endometrium. Hysteroscopy is our important diagnostic tool, and we can correct, define intrauterine pathology as well as try and correct it. And it has been suggested by some that just doing the hysteroscopy increases the endometrial thickness through some immunological mechanism. Of course, this has not been validated at all. When it comes to management, if there are iatrogenic causes like drugs, then well, you stop or change your drug. Remember that if you have been giving prolonged clomiphene citrate, it may take very long for your basal layer to start getting active again and for the endometrium to start regenerating, and you need to have patience to get that and not get hassled about it. But the real problem arises in surgery when extensive curettage has been done or resection has been done, or in radiotherapy where there is vascular insufficiency or fibrosis. And what happens here is that there is damage to the basal layer of endometrium, which, as we know, is the layer which is responsible for regeneration of the endometrium. In chronic endometritis, especially genital tuberculosis, again, the biggest problem is destruction of the basal layer, because healing occurs by fibrosis even on treatment. And therefore, to try and generate endometrium despite normalizing the cavity after cutting adhesions becomes a very, very difficult issue. So what are the proposed treatments? The treatments will fall under certain headings. A hormonal treatment is estrogen exogenous, and we know that this is the mainstay of our treatment in frozen embryo transfer cycles. We can use take the help of endogenous estradiol by giving drugs for ovulation stimulation, or HCG. You can improve vascularity by giving all these drugs, or what is new now is the use of regenerative strategies using growth factors or stem cells. Estrogen administration, what do we do in this? We try to increase the dose, we try to increase the duration, we try to change the route of administration, even change the molecule type to try and see whether we can achieve a better endometrial lining. Now, according to some studies, or one particular study, they said that the natural estrogen does worse than the synthetic estrogen in terms of the endometrial buildup. However, in my experience, there are some people who only build up the lining with natural estrogens and not with the synthetic estrogens. So it is very patient dependent. Sometimes what we do is we do repeated cycles of HRT to try to get that basal layer to start functioning, and then add onto it all the other add-ons that we have. If endogenous estradiol is helpful, then what we do is give tamoxifen, 40 milligrams for 5 days, and look at the endometrial thickness. And in many patients, this really works. Giving gonadotropin also works. Medleucel, GnRH agonist, has been tried, giving one at 0.1 mg at OPU and ET, and then 3 days after. However, so far as the agonist is concerned, we don't have enough evidence to suggest that it should be used as a routine for improvement of the endometrium or for improvement of pregnancy rates. HCG has been given. It is thought that the local paracrine actions will help to improve the endometrium in the follicular phase. So it is given either before ET, it is used intrauterine, or it can be given subcutaneously for about 8 days, 7 to 8 days, starting from day 8 of the cycle. Again, the evidence regarding the use of this is not sufficient, and you may not find any change happening if you use the HCG. Then look at the drugs which are used to improve vascularity. We have sildenafil, pentoxifylline, vitamin E, arginine, and nitroglycerin. Of these, I think sildenafil and arginine are the two most used. Sildenafil in a dose of 25 milligrams every 6 hours vaginally till HCG trigger or ET, and arginine is given 6 milligrams per day on a daily basis. And it is thought that apart from improving vascularity, it activates the immune system. If any of you have used nitroglycerin, then you know that even though the vascularity may improve, endometrial thickness does not necessarily improve, and the patient has severe headaches and severe side effects with these patches. So when we look at the effect on RI and endometrial thickness and pregnancy rate, we find that in some studies, arginine and sildenafil show an improved rate. However, at the moment, they may be promising, but the strength of evidence for their use is still very weak, and they are really not recommended. Then we come on to aspirin, which is something which we use on a very, very regular basis. All of us are fond of using this because it reduces subendometrial contractility. It minimizes inflammation by inhibiting cyclooxygenase and prostaglandin biosynthesis. It improves the endometrial blood flow by decreasing uterine artery impedance. However, what has been seen in some studies, they have shown that yes, endometrial thickness does increase, but really pregnancy rates do not show much effect for this particular drug. So again, if we are looking at just endometrial thickness and improving receptivity, well, then again, there is a big question mark. So when you look at all these therapeutic options that I have just, suggested or talked about, you find that they're all reds and oranges. We really don't have any green, anything to show us that, all right, this is an effective strategy and let's get on with using this. So what do we do? And then in search for something, we moved on to using growth factors. And the first growth factor that was used was GCSF, that is the granulocyte colony stimulating factor. These receptors are expressed on the trophoblastic cells as well as the granulosa cell. It acts as a growth factor and cytokine and stimulates proliferation and differentiation, and also endometrial stromal decidualization, and it modulates gene expression. So all very good on the growth factor front. It is given either as an intrauterine infusion, where 30 international units or 300 micrograms are given, at least in this study, were given 6 to 12 hours prior to HCG, and then again repeated on the day of OPU. Another study suggests that you can just give subcutaneously 300 microgram on day 14 and 16, and it's as effective. However, the one thing that I would like to point out for GCSF is that please do not give it too close to your embryo transfer, because you may carry infection from the vagina up into the uterus, or the fluid may still be there when you're doing the embryo transfer. So if you are going to use it a little early, so that it's well absorbed into the endometrial tissue. Now, in this particular study, we always have evidence for and against. So in this particular study by Kuniki in 2014, and then he did another one in 2017. And what he found was the endometrial thickness does increase. But of the patients who conceived, they were similar in both the groups, where the endometrial GCSF had been used and where it had not been used. So another well-designed RCT again was unable to demonstrate any effect of GCSF on endometrial growth or the pregnancy rates in IVF. So for the moment, it does increase EMT and FET cycles, but there is no potential to improve pregnancy outcome, and maybe more studies in future will tell us if it really works. So then we come on to the new kid on the block, which is the platelet-rich plasma, which is really making waves in all the disciplines of medicine. Platelet-rich plasma enhances the body's innate ability to repair and regenerate. Platelets excrete several growth factors and cytokines that are associated with healing and regeneration, such as PDGF, VEGF, TGF, IGF, and EGF, and they also have an antimicrobial activity. However, for the tissue reparative efficacy to actually work, you have to concentrate the platelets to more than 5 times the normal concentration. And the ideal concentration, of course, we still don't know, and the exact mechanism of how it works still remains to be elucidated. Now, how do you prepare this? 15 ml of blood is taken in a syringe filled with anticoagulant. It's centrifuged at 200 G for 10 minutes. You get a buffy coat. You take the buffy coat and the plasma layer above it, recentrifuge it at 500 G for 10 minutes, and then the resulting pellet of platelets is mixed with 1 ml of supernatant, and 0.5 to 1 ml of PRP is obtained and infused into the uterine cavity. Now, again, I want to tell you, just like we do in IUI, we use only about 0.3 ml of preparation, because if you use more, the cavity does not take it and it's all going to trickle out through your os. So you use a smaller amount, 0.3 to 0.5 ml, infuse it very slowly into the uterus, allow the fluid to spread, or the platelets to spread amongst the endometrium, so that when you withdraw the catheter, nothing comes trickling out of the os. Now, this was the first study which actually showed the benefits of PRP, and there were 5 patients with Asherman's with very, very poor endometrium, 6 or below, and all of them had an improved endometrium after PRP infusion. It was 1 or 2 infusions that were done, and all of them got pregnant, with 4 of them going on to ongoing pregnancies. Now, IUPRP also helps in improving inflammation and receptivity. It is believed that in chronic endometritis, probably the antimicrobial, anti-inflammatory properties correct the endometritis, and the growth factors, which play an important role in cell proliferation and neoendothelial cell generation. And these are important or key factors in endometrial receptivity. So apart from the growth of the endometrium, they also improve or enhance the endometrial receptivity. And this study, the recent study by Ferrara, it evaluated many studies, and there were 2 RCTs within this group. And in both the RCTs, it was shown that the endometrium significantly increased in thickness after the installation of PRP. So this particular therapy does show promise, though we need more studies. Now, in our own setup, we have looked at endometrial receptivity, with improving endometrial receptivity with IUPRP, because we find that the receptivity in thin endometrium is altered really in only 20 to 25% patients, just like in other REF patients. So nothing exceptional there. And what we found was, when we added PRP to these patients who had by era a receptive endometrium, the pregnancy rate shot up to 68.4. So this suggests that PRP is definitely doing something to the receptivity. The growth factors are adding on to the effect. Going then on to stem cell therapy for endometrial regeneration, we know that there are stem cells in the basal layer of the endometrium, and these are involved in regeneration and repair of the endometrium through direct differentiation or through paracrine effects. Now, apart from the endometrial stem cells, you can have stem cells from bone marrow, umbilical cord, and adipose tissue. The bone marrow's stem cells are supposed to have the greatest effect on uterine regeneration. Safety and effectiveness have been demonstrated in trials. So one of the first studies which came was from Carlos Simon group, and what they showed was that when they took bone marrow and mobilized the CD133 plus cells through apheresis, and then delivered it into the spiral arterioles by catheterization. And these were patients with severe Asherman syndrome. They improved their lining, and in the vessel density improved, the menses improved, and pregnancies were achieved. So what they felt was that these cells regenerate endometrium and modify the immunological milieu which precedes proliferation and angiogenesis. Menstrual blood has also been, stem cells from menstrual blood have also been used. And actually it is so non-invasive. They have a high proliferative capacity, low immunogenicity and tuberogenicity. They would be ideal, but unfortunately, the isolation of these cells has not been done very successfully by a lot of people, and we are still at a standstill on this. Stem cells from adipose tissue have also been used to increase endometrial thickness, very successfully at that. So the adipose tissue is taken out through liposuction. And now we have our very own study case report from Dr. Patel in Ahmedabad, where they collected the bone marrow aspirate and separated the cells from it after centrifugation. And then these cells, about 15 million cells per mil, were administered to the patient using the same thing as we do for cardiac cath. There is a femoral artery is accessed, and you access the spiral selective cannulation of the uterine artery is done through that, and then subsequently the spiral arteriole, and the cells were deposited into the uterus, and they achieved good endometrium and live birth through a lucid donor cycle. Now, all this is really exciting and wonderful, but unfortunately, because of this aspect, because of the femoral artery catheterization that is required, it is not going to be so easily available to clinics across the board. Last but not least is the use of stem cells in oncofertility. We know that through hormone therapy or curatages in endometrial cancer and radiotherapy leading to destruction of the endometrium, stem cells would really be a boon. The mesenchymal stem cells can inhibit tumor growth and angiogenesis, but there is still a controversy on safety, and till that is cleared, we cannot really afford to use anything in patients who have been suffering from a terminal illness which can be terminal in nature. But if we do get it, then we improve menstruation and help to enhance female fertility. How do we improve the viability and efficacy of these cells? Because when you put in the stem cells, many
how many slides are left?
materials like hydrogels and scaffolds, which create the niche, the stem cell niche, and allow for better efficacy and viability of these cells. These have been used, and hopefully we should hear more of this in future. So to conclude, thin endometrium remains a challenge, but endometrial thickness alone is not predictive of IVF outcome. Hysteroscopy forms the basis of our diagnosis. We need to treat endometritis, change our drug protocols if they are the problem, give HRT cycles with high doses of estradiol. Along with that, you can add IUPRP in the hope that the endometrium will regenerate. Stem cell treatment may be the future. And with that, I'd like to thank you all for a patient listening.
Thank you, Dr. Nalini, for a wonderful talk on refractory endometrium. So our next speaker is Dr. Sonia Malik. Welcome, Dr. Sonia Malik, to ACE 2021. And we are all familiar with Dr. Sonia Malik. She's past president, IFS, and chair Infertility Committee, FOXY, past president, Indian Menopause, associate editor, Southeast Asia Journal of Global Health, member editorial board, Fertility and Sterility India, member editorial board, Journal of Reproductive Health Medicine, editorial board, Journal of Fertility Science and Research, and she's also scientific collaborator, Reproductive Research Center, Cleveland Clinic, USA. She is member ICMR Task Force on Genital Tuberculosis. So, welcome Dr. Sonia Malik. Her talk is going to be on endometrial tuberculosis and ART.
Thank you very much. Thank you very Subarna. Like thank ACE for always putting me in their programs. Why this sound is resounding a lot. I don't know what. Anyway, can you allow me to screen share, please? Hello?
You can try sharing your screen.
Can I share my screen? Yeah, okay.
Yes.
All right, here it is. So before I begin, I would like to congratulate the organizers, and especially Dr. Gautam, for making me a part of this historic meeting, wherein the father of IVF has been brought home. It is a very proud moment for all of us that the due recognition has been given to him. And I congratulate Dr. Gautam and his team for the continuous crusade that they have carried on to bring this about. And thank you very much for making me a part of this. With this, I start my presentation on endometrial tuberculosis and ERT. Dr. Nalini has referred to this in her talk also. And we all know a lot about genital tuberculosis now than what we did a couple of years ago. We all know that it is an insidious disease, especially when it is present in the uterus. And it is incidentally uncovered while we are looking at the endometrium in infertility patients. It is basically in 5% of all infertility patients. That is what has been reported. So then, why is it so important to understand genital tuberculosis? Because it is an opportunist infection, and we all know now with the corona thing coming in, we all know that it is the immune system which plays a huge role in all chronic infections and also in acute infections. And basically, it is the labile immune system of the woman which gets activated at times when the immunity is low, and then causes a problem within the endometrium. The clinical presentation, therefore, of endometrial tuberculosis would be infertility with no signs and symptoms, infertility with some signs and symptoms, and also recurrent pregnancy loss, which is not talked about so much. So if you look at the prevalence studies of genital tuberculosis from India, you find over here that majority of these studies have actually talked about tubal factor infertility, and we really did not know so much about the endometrial element of it till a couple of years ago when we started looking at the endometrial biopsies and new tests came in. So what is the effect of endometrial tuberculosis on endometrial function and structure? It is intense actually, and it causes endometrial atrophy and synecdoche formation, and leading to a thin endometrium that Dr. Mahajan referred to. Due to involvement of the endometrium by caseous and fibrocaseous lesions, it causes Asherman syndrome. We all know that. And the adverse effect on the endometrial markers, which are essential to make the endometrium receptive, are also affected. There is defective vascularization and activation of the antiphospholipid antibodies in the endometrium. Subendometrial blood flow is also affected. So in totality, the entire basal layer and the endometrium per se is affected in many cases of tuberculosis. So when you look at it, our greatest asset has been the ultrasound, and we all know that there are ultrasound markers of endometrial tuberculosis. When it is mild endometritis, it is irregular, thin, broken endometrium, which does not conform to any cycle or any phase of the cycle, and therefore makes us suspicious of something happening in the endometrium. However, if there is moderate to severe endometritis, you may find either fluid or synecdoche and old calcification also seen as bright spots within the endometrium. But when you look at the endoscopic evidence, which is actually something which has revolutionized our thinking of tuberculosis, we find that it gives rise to all kinds of bizarre pictures. And therefore, there are adhesions right inside. And many a times it is so bad and intense that you may even find caseous material inside the cavity of the uterus whenever you are doing hysteroscopy. And all these things can lead to what we have been finding in radiology all these years as pictures of Asherman syndrome. So basically, it is a totally destroyed and distorted cavity, which actually can be seen on hysteroscopy. And basically, this was a very beautiful report which was published in 2007, where this group looked at the endometrium after giving anti-tubercular therapy, and they found that the endometrium had cleared up after this moth-eaten appearance that it had initially. So active disease, of course, should not be handled, and post-medical therapy or relook surgery is very, very effective. And basically, there are two reports from India. There may have been many others, but these are two much quoted reports from India. This one is from Mahukal, which was published in 2015, which reports 105 cases, and Dr. Asha Bakshi's study, which reports 174 cases. If you look at the outcomes in these two, you find that the same kind of lesions are reported with the same kind of frequency in both these studies. So basically, intrauterine fibrosis and overall total PCR positive was nearly the same in both of the studies. So we cannot disregard PCR as being one of the tests for genital tuberculosis. We are closely coming now to understanding the fact that yes, PCR is telling us something and we cannot disregard it. So then eventually what happened is ICMR gave a call to understand genital tuberculosis, and many studies were taken up. And this is a very nice elaborate study which has been taken up by Dr. B.N. Chakravarti's unit here in Calcutta. And he looked at the biochemical markers. They looked at the biochemical markers in the endometrium, and they found that all these biochemical markers which Dr. Sarogi had mentioned in his first talk are actually disturbed in these cases of endometrial tuberculosis. And also they looked at the pinopods, and they found that in genital tuberculosis, they were poorly developed pinopods, meaning thereby that basically this is leading to a distortion and a non-receptive endometrium inside the uterine cavity. So therefore the implantation is affected. So, but clinically or easily available is basically looking at the immunohistochemistry, which actually tells us the presence of plasma cells in the endometrium. So CD138, if it is positive in the endometrium, then it is a case of chronic endometritis. And in addition to that, if you find PCR positive or if you find other granulomas, etc., then you can be sure that this chronic endometritis is actually tuberculosis. So regarding the perifollicular Doppler or regarding the blood flow variation, this was a study which was published from All India Institute, Tina Malhotra and team, and they found that basically all these, the blood flow in these patients is definitely disturbed. And you find that in this study, they found that in many of these patients, there was definitely a distortion of the blood flow or absent blood flow also in the endometrium. So the confirmatory tests, as we all know, are the AFB culture, rapid cultures like BACTEC, and of course the evidence of granulomas on histopathology. And now the new one, which is still to actually prove its worth in endometrial tuberculosis, is GeneXpert, where you do not find such good results in the endometrial biopsy samples. However, the PCR for endometrial tuberculosis, although it is supposed to be a doubtful evidence, has actually revolutionized our thinking of tuberculosis in the genital tract. And latent endometrial tuberculosis is something that we are all very, very familiar with now as gynecologists. And we all know that basically, in addition to the PCR, like I mentioned, the presence of plasma cells and indirectly quantiferon gold can tell you about the immune status of the patient. And therefore, if you put the two together, then you may reach a diagnosis of endometrial tuberculosis. So what is the management then? You have the mild disease with no structural defects, which is where you are just going to do medical management. Moderate disease with some stigmata, where medical and if surgical management is required, you may have to do it. But in severe disease of the endometrial cavity, you do need to have a surgical intervention. You have to correct that distortion and of course offer ART. Both in mild and moderate disease, ART may be offered to the patient if she does not conceive after completion of treatment of the medical treatment. So basically, ART can be offered to all the three types of patients, because endometrial tuberculosis is not going to be present singularly. There will be a problem with the tubes, there may be a problem with the ovaries, and hence, if she does not conceive after a medical management, you may have to resort to ART in any of these cases. So this is the outcome of some of the Indian studies that have been published over the years. Some of them are also indicating ART. For instance, Dr. Firoza Parekh's seminal paper, which came after in 1997, where she had looked at laparoscopic evidence of tuberculosis and then followed by ART, giving a pregnancy rate of 16.6%. And in 2006, when Dr. Jindal et al. And of course, Dr. Chakravarti also reported results of ART to the tune of 31.2% and 29.2%. Some people have used treatment as a sole after doing a PCR and then putting the patient solely based upon the positive PCR and in mild disease. And this is not only in India, but in other countries as well. But I have quoted only the Indian studies where the latent tuberculosis has been diagnosed by a positive PCR. And based on that, all these people have actually given ATT to these patients and reported a 30 to 40% pregnancy rate in all these reports. So basically, that I'm just trying to reiterate that PCR should not be neglected. But of course, we all know that a sole PCR positive is not basically enough to diagnose tuberculosis. We also looked at RPL in female genital tuberculosis, like I mentioned, and this is a very recent report of 2019, again from Calcutta. A large number of patients, of 317 patients of unexplained RPL were enrolled, out of which they found 34.4% were with tubercular regions and 42.3% had latent tuberculosis. So basically, a large segment of this 317 patients were actually tubercular and were having recurrent pregnancy loss. We also published a study in 1986. And again, if you see in both these reports, the term pregnancy after treatment was 37.5. And here I am also reporting a pregnancy rate of 41.6%. So basically, treating tuberculosis is quite gratifying. You do get a good pregnancy rate, even in patients where they are presenting with recurrent pregnancy loss. Then what about ART per se? Now we know that it causes tuberculosis can affect the ovaries and actually affect the ovarian reserve, thereby having poor response. They require more gonadotropins. The quality of oocytes may be poor. And what we are concerned with now is the poor endometrium and low implantation rate and pregnancy rates that happen with tuberculosis. And if you look at these papers from across the world, although there are not many published reports on genital tuberculosis and IVF, but if you look at these reports, the number of patients also is quite less. However, we reported this in the year 2010 with 120 patients. And if you look at these, you will find that the pregnancy rate increases because of the type of test that has been used to detect the tuberculosis and how early or late the tuberculosis has been used. Here there is a high pregnancy rate, but the number of patients is very low, and there were only 6 patients who had a pregnancy. So basically, yes, the implantation rate is less. And of course, there are abortions and ectopic pregnancies, but then getting a number of patients pregnant out of this whole lot is also very gratifying. So ART does give a very good result in patients with endometrial tuberculosis. So what about patients who have a very bad endometrium which does not actually respond to anything? So basically they are offered third-party reproduction, and we also know the indications of surrogacy, moderate to severe intrauterine adhesions, atrophy of the basal layer, grossly reduced endometrial thickness, dense pelvic adhesions, and unexplained repeated IVF failures with endometrium showing granulomas, etc. So basically, these are some of the indications, and this paper was published in the book Genital Tuberculosis, where this group, again from Calcutta, reported their results of surrogacy from 2002 to 2006, a total of 14 cases, where the uterine synecdoche was one of the indication, poor endometrial development was another, and of course repeated IVF failures. So they were able to get pregnancies through surrogacy in these patients as well. And so although surrogacy may not be giving very good results because of the ovarian component of genital tuberculosis, the oocytes may not be very good, but yes, some of the patients where it is only the endometrium which is causing a problem, it may actually result in good pregnancy rate in such patients. So basically, therefore, to conclude, endometrial tuberculosis can cause recurrent implantation failure in IVF due to its overt anatomical effects on the reproductive system and its latent physiological and immunological effects. So therefore, it is important to understand the nuances of this disease in order to treat these patients well. With that, I thank you very much for having me here with you. Thank you very much.
Thank you, Dr. Sonia, for your lovely presentation. We might have a lot of questions. I think it is very pertinent because we all suffer from these patients are very difficult patients to treat. So we'll discuss the question, I think, after our last session. Hello. Okay, so the next session is role of stem cell therapy in endometrial pathology. And the speaker is Dr. Niket Patel. Okay, so Dr. Niket Patel, he awarded B. Nirmala Swamy Gold Medal for MD Obstetrics and Gynecology in 2016. And got a German diploma in basic and advanced minimal surgery, access surgery, and fellowship in basic and advanced minimal access surgery, diploma in reproductive medicine, and specialized training in fertility preservation and OTCP. And his area of interest is endoscopy, infertility and endometriosis, fertility preservation, and polycystic ovary syndrome. The stage is all yours. Can you please share the presentation, please?
Hello everyone. At the inception, I'd like to thank Dr. Gautam Khastigar and the entire managing committee of ACE 2021 to have given me this opportunity to speak on the topic of role of stem cell therapy in endometrial pathology. Despite remarkable improvements in IVF technology and resulting pregnancy rates, a significant proportion of infertile couples still fail to conceive. Now, what are the factors responsible for IVF failure? As we all know that endometrial thickness, poor ovarian reserve, oocyte quality, improper embryo transfer, inadequate luteal phase support, and sperm DNA damage appear to be the major factors. But today, we will be focusing on the endometrial thickness. Now, in endometrial thickness, how thin is too thin? Often in our textbooks, thin endometrium is defined as thickness below 7 or below 8 millimeters. Obviously, if you would use the cutoff to be less than 8 millimeters, then the incidence would be much higher as compared to if you use a cutoff of less than 7 millimeters. If you look at the physiology of endometrium, there are two layers, the basal layer and the inner functional layer. The embryo usually implants on the functional layer. The basal layer is the layer which stays intact during the menstrual cycle and consists large spiral arterioles. Now, during the thin endometrium, the embryo implants closer to the basal layer. Now, what happens then is that because of the close implantation, there's a copious blood flow and high oxygen tension, which results in creation of more reactive oxygen species, which interrupts with the embryonic development and implantation. Whereas in the functional layer, as you can see, if the functional layer is thick and the embryo implants into the functional layer, then there is reduction in the oxygen tension in the functional layer, which improves and facilitates the implantation. Now, what are the causes of thin endometrial thickness? If there's a history of dilatation and curettage, any postpartum endometritis, any septic abortion, fibroids, radiation, all of these factors lead to thin endometrial thickness. And in terms of physiology, if there's a resistance in the circulating estrogen or reduced blood flow to the endometrium, damage to the basal endometrium, and the oxygen tension theory, all of this cumulatively give rise to thin endometrium. And the impact of thin endometrium in turn would be reduction in the implantation rate, clinical pregnancy rate, and obviously the live birth rate. The endometrial thickness is considered to be best when it is between 8 to 14 millimeters of thickness. If the endometrial thickness is less than 7 millimeters, that is if it is too thin, or if it is more than 16 millimeters, that is if it is too thick, then it is not considered conducive or ideal for endometrial transfer or endometrial implantation. In terms of management, we know about the basic management. That is, for thin endometrium, we have always been doing the hysteroscopic visualizers, hormonal manipulation, improving the endometrial perfusion with the help of various drugs. But what we will be focusing on today is the novel technique of treating thin endometrium with regenerative medicines and stem cells. So the cell-based therapy for thin endometrium. In regenerative medicine, which is the most recent and emerging branch in the medical science, it deals with the restoration, functional restoration rather, of tissues or organs for patients suffering from severe injuries or chronic diseases. Regenerative medicine is a branch of translational research in tissue engineering and molecular biology, which deals with the process of replacing, engineering, or regenerating human cells, tissues, or organs to restore or establish normal function. Stem cells are differentiated cells that are present in the embryonic, fetal, and adult stages of life and gives rise to differentiated cells that make up the building blocks of the tissue and organ. Now, this very point is very important, that stem cells have the ability to branch out and change or differentiate into two or more different cell types. And moreover, they also possess the ability to develop into functional and differentiated cells. This was one of the very first updates by Weck-Boyner, wherein the cellular therapies for endometrium were given a face. What they included in that was that due to the infection and inflammation due to various exogenous factors, there was an unbalanced breakdown or repair of the endometrium, which resulted in the defective endometrial healing. Also, moreover, this defective endometrial healing then led to intrauterine adhesions. These intrauterine adhesions were dealt with in two manners. One is hysteroscopy. Obviously, you need to release those intrauterine adhesions. And secondly is by cell therapy. In cell therapy, they did an intra-arterial catheterization and injected CD133 cells through that. Also, a subendometrial or transmyometrial injection of bone marrow-derived mononuclear cells was done, and the intrauterine infusion of mesenchymal stem cells was done. What is the experience at our center? In our center, in terms of the cell-based therapy, we have categorized it into PRP, which is obviously can be done in a form of powder PRP, which is available in a lyophilized form, and autologous PRP, which is derived from the patient's own blood. And in cell therapy, there is bone marrow-derived stem cells and the umbilical cord stem cells. The three methods of installations include the intrauterine installation, which is exactly how we do in embryo transfer. That is, it is done in the same cycle as the embryo transfer, a few days prior to the embryo transfer. Subendometrial, insertion of the bone marrow derived stem cells, a video of which I'll be showing later on in the lecture. And it can also be implanted or injected directly into the uterine artery spiral arterioles. Now, this was a pilot study of 10 patients for thin endometrium done at our hospital by injecting bone marrow derived concentrate in spiral arteries by uterine catheter. And this was inspired by this study from Carlos Simon, wherein he isolated CD133 cells from peripheral blood apheresis and which then were immediately delivered into the spiral arterioles by catheterization. And if you see the results, they are really encouraging, as in Asherman syndrome, which is the worst category of endometrial lining or the endometrium you can ever get. They saw an endometrial thickness increase from an average of 4.3 millimeters to 6.7 millimeters. In endometrial atrophy patients, they saw an improved endometrial cavity and endometrial thickness from 4.2 up to 5.7 millimeters. So the cell therapy increased the mature vessel density and increase the duration and intensity of menses in the first 3 months after the procedure. Now, how this procedure helps? This stem cell therapy targets the endometrial niche with the ultimate aim of replenishing the cellular compartments of the functionalist layer and offers a promising possibility for treating Asherman syndrome and endometrial atrophy. Obviously, to do this, we will need an ethical approval and also a certificate from the Department of Health and Research and certificate of good laboratory practice. And you would need an advanced setup in terms of a cath lab, a molecular lab, an advanced OT, all the machinery and equipment necessary to go ahead with the procedure. Now, pre-procedure, we give the patient an antibiotic, mostly these cephalosporins, which are the safest categories of antibiotics. Apart from that, we also give patient oxygen at the rate of 2 to 4 liters per minute for 30 minutes, and glutathione and in the dose of 600 milligram, and vitamin C at 150 milligrams, as this helps in the peripheral mobilization of the stem cells. Now, this is the procedure of how we do the aspiration of the bone marrow. As you can see, this needle is inserted into the iliac crest, that is just besides the anterior superior iliac spine, and then a negative suction pressure is exerted by our doctor, and there's a free flow of the bone marrow fluid that you can see. This is nothing but the bone marrow aspirate. Now, once this is done, this is then sent to the lab wherein stem cells are isolated from this bone marrow aspirate. This is the procedure wherein overlaying of bone marrow aspirate on top of Ficol pack is done, and hence it is separated into different components, after which the cell counting, characterization and treatment is done. There is also a machine called as SAPEX, which is the bone marrow processing unit, which claims that they harvest up to 52% more cells, which is approximately 312 million more cells, which gives you approximately 912 million cells if you get an aspirate of close to 60 to 80 ml. Now, how do these stem cells act? Bone marrow derived stem cell concentrate contains hematopoietic stem cells, mesenchymal stromal cells, and endothelial progenitor cells, which in combinations have the capacity to integrate into damaged tissues and transdifferentiate into host tissues. Now, this is my video on how we inject the stem cell concentrate hysteroscopically into the walls of the uterus, into the subendometrial layer. So as we inserted the hysteroscope, we could see some amount of fundal fibrosis present. So we dealt with it with the hysteroscopic scissors, and you can see me giving timid cuts and cutting the area of fibrosis, after which this needle, which is the egg retrieval needle, is inserted through the port of the hysteroscope, and the stem cells are injected into all the 4 walls, that is the 2 lateral walls, anterior walls, and the posterior walls. And after the insertion, we wait at least for 30 seconds for the stem cell concentrate to be absorbed completely, after which we change the wall, and finally after completing all the 4 walls, we will come out and the hysteroscopy ends. This is the cath lab setup, wherein if you want to instill it directly into the uterine arteries, spiral arterioles, this can be done in the cath lab by gaining access through the femoral artery. So what happens here is, this is basically the video of the cath lab procedure which is being done. As you can see that the access is gained through the femoral artery, ultimately moving up to the uterine artery, and then you will be able to see a fantastic flow, as you can see, into the spiral arterioles within the myometrium of the uterus, and this gives excellent results. So this was one of our very first cases, and we have also a case report in our name, wherein a 26-year-old female who was suffering from primary infertility was diagnosed to have refractory endometrium due to history of tuberculosis previously. She also had previous history of 3 failed IVF cycles due to thin lining. Now, we prepared for the IVF cycle in May. The endometrial lining was 7 millimeters. That is, we did the procedure, this procedure of inserting the stem cells into the uterine artery spiral arterioles. And after which the lining developed up to 7 millimeters, and after which the embryo transfer was done in May 2019. And ultimately, the consequence was delivery of a healthy baby boy in February 2020. So these are the pictures of, you can see how wonderfully the lining has developed after the therapy of, the stem cells being injected into the uterine artery spiral arterioles. And this is the baby that had delivered. And this is one of our latest publication in SERMS where we had published this report. We've done a total of 11 cases, out of which embryo transfer is done in 5 of those patients, wherein 3 patients have delivered. 1 is a single pregnancy, 2 twins, and 3, those 3 patients who have delivered, out of that 2 were twins and 1 was a single pregnancy. 1 patient still has an ongoing pregnancy. 1 patient has embryo transfer, to be done next month, and the remaining transfers are pending. I mean, the BMDC therapy is done already, but the embryo transfers are pending. Now, if you want to treat patients with stem cells in India, basically, you need to know about the guidelines, wherein the therapeutic use of stem cells, other than the proven indication, shall be treated as investigational and conducted only in the form of clinical trial after obtaining necessary regulatory approvals from DCGI and NAC. The notification that has come out, however, does not touch upon the use of autologous stem cells, where the individual's own stem cells are collected and minimally treated before infusing it back into the patient. So in conclusion, the endometrium is an essential part of embryo implantation process, and inadequate endometrial growth is associated with lower possibility of pregnancy. And cell therapy is now being considered as potentially new therapeutic agent for treatment of infertility due to their high differentiation potential. So cell therapy trials for treatment of endometrial pathologies have reported promising findings with demonstrable safety and early proof of efficacy, temporary amelioration of intrauterine environment, and an increase in the endometrial thickness. Now, the focus should be on translating these findings to an improvement in the fertility. It is therefore essential that further preclinical studies are conducted using human material to enhance our understanding of tissue regeneration in endometrium and the factors that regulate these processes. Thank you so much for your patient listening.
Oh, okay. It's an excellent presentation, Dr. Patel. And it shows that our science has improved so much, though it is very challenging to use in other clinics, and you need a lot of setups, but it is excellent to know that we can help those unfortunate patients where we cannot do anything else. Is there any question we can discuss now?
Suparna, I don't see any questions in my chat box. And so Varun, hello? Varun?
Yes, ma'am.
Yeah, do we have any questions, and do we have any time for question answers? Or
No, ma'am, we have not received any question on the website yet.
okay.
Yeah.
So you can proceed with the next session now.
Okay.
Thank you.
Yes.
Thank you all.
Okay. Thank
For
you,
the next,
everyone.
the session
Thank
will be
you,
at-
the organizers of ACE 2021. So,
Thank you
and
for
wish
having
you
me here.
good
Thank
luck.
you.
Yeah.
Thank you very much.
Thank you, Dr. Sonia, for such a wonderful presentation.
Thank you.
Thank you, everybody.
Okay. Bye.
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 Varun, we move to Hall A for the.
Yeah, ma'am, the oration, Dr. Subhash Mukhopadhyay
Yes.
oration will
Then,
start at
give
11.
Give us the link.
I'll be sharing you the link for that. It's a
Yes.
website link, not a Zoom link. You have to tap on that, and then that will take you to the hall link.
Send it in my WhatsApp.
Sorry. Yeah, I'll share on WhatsApp.
Hmm.
In group as well as individually, I will send you.
Varun, have you sent?
Sending, ma'am. Sending in a minute.
Okay, okay. To all of you, and it is my proud privilege to welcome such a glorious personality like Dr. Pranav Dasgupta. And he's a very multifaceted person. I'm really proud to have this opportunity to introduce him today on this prestigious platform of ACE. Now, his professional qualifications, schooling and college at Bangalore in St. Joseph's College, and studied at Arjikar Medical College. And from 1970-74, he obtained postgraduate degree from Chandigarh. 74 to 80, DGU MD FRCG degree from London. Professional qualifications, naturally, MD FRCG DGO, consultant gynae obstetrician, consultant in infertility, laparoscopy consultant. He is associated as head of the gynecology obstetric at Ambri Group of Hospitals, Kolkata, India, head of the Department of Fertility Clinic and IVF Research Center and Vision Care Hospital, Mukundapur, Kolkata, visiting consultant at Bhagirathi Nepia Women Child Care Hospital, Kolkata Bellevue Hospital, Woodlands Hospital. Thank you, sir. And the next chairperson, please. I'm very proud to introduce
Dr. Indranil has not joined.
Okay, then Dr. Duru
Then we
Shah.
can start the session. So thank you very, very much for such a kind introduction. Now we move to the next session after a wonderful oration that you all heard recently, just 5 minutes back. We have got 3 speakers for this session. The first speaker is Professor Duru Shah. She'll be talking on enhancing endometrial receptivity. Now, because it's short of time, then I'm not going to introduce her separately. She doesn't need an introduction. So Dr. Shah, could you kindly start your lecture, please? Thank you very much. Dr. Shah, we'll be happy to...
Good morning, ladies and gentlemen. First of all, I'd like to thank ACE for having invited me to this very prestigious Congress of ACE Kolkata 2021. I personally thank Dr. Gautam for having invited me. My talk is related to enhancing endometrial receptivity. And this is something which we are all dealing with on a day-to-day basis. And I'm going to give you a brief of what really is happening today with endometrial receptivity, and something which we all need to understand as to where is the problem. I think most of the audience consists of embryologists, and therefore I will be very brief where the clinical aspect is concerned and focus more on the embryological part. Now, we have issues when a failure of IVF occurs. We know there could be either maternal issues, there could be anatomical, where something is wrong with the uterus, for which we actually, the intervention we perform is we do a salpingectomy or block the tubes if there is hydrosalpinx. If there are fibroids, we remove the large fibroids prior to the doing the embryo transfer, or if the fibroid comes in the way of an ovum pickup, we remove the fibroid, we freeze the embryos, wait for the surgery to heal, for the uterus to heal, and then do the transfer maybe 4 months later. Then we also, if we have a polyp seen on the ultrasound, when we have gone through the baseline ultrasound, we do a polypectomy, remove the polyp, because that comes in the way of a pregnancy success, and at the same time we assess the endometrial growth and see whether the thickness, the blood flow, etc. is good in the endometrium. We also look for thrombophilia in such patients, because if there is thrombophilia, that is a clotting defect, we always would start low molecular weight heparin in such patients, or sometimes aspirin. Genetics is something we are always looking at. If there's a family history of a genetic disorder, we would like to do a pre-implantation genetic diagnosis, and we would do karyotyping for the embryo, so that we can rule out any evidence of a genetic abnormality in that embryo. And today we are also looking at immunological conditions, and if we do find an immunological problem, we may treat her with tacrolimus intravenous immunoglobulin, peripheral blood mononuclear cells, and GCSF. These help in the growth factor, or in the modulating the antibodies in the system. If there's chronic infection found in the endometrium, we would like to give antibiotics. There are studies done wherein we do the CD4 calculation of cells, and if the cells are more than 5 per high power field, we would like to give them long-term antibiotics prior to transferring the embryos. And then, of course, we have altered molecules and endometrial receptivity, which we look at, and there is a possibility of doing an endometrial scratch injury into the endometrium, so that there is some amount of inflammation created, which can help later in the invasion or the implantation of the embryo in the next cycle. And then you have the growth granulocyte cell stimulating factor, which can also be injected intrauterine, which will help to improve endometrial receptivity. There are other factors like the embryo, wherein we could do a PGS or a PG or PGD to confirm its quality, the male factor, where we can advise him to stop smoking with juvens, and IMSI may have a role. And of course, you have the IVF protocol, where you optimize the protocol according to the kind of patient you're dealing with. We need to actually make sure that we are looking at the clinical parameters of each patient, rather than only looking at the endometrium or the standardized protocol, which we, with some centers, tend to follow. So when it comes to an endometrial embryo's asynchrony or synchrony, we must make sure that we have an anatomically normal uterus. Though on ultrasound it may look very normal, but when we do a very intense imaging techniques, we can actually look at the uterine contractions. And if there are excessive uterine contractions in the luteal phase, it can lead to an implantation failure. Second is if there's an abnormal endometrial microbiota, which I have talked about, which can be detected by molecular techniques, and this could be the cause of implantation failure, wherein the endometrium looks completely normal, but when you do the test or the CD4 cells, and you'll know that there is an infection, you have to treat it prior to transferring the embryos. And the third, of course, is the most common, the displacement of the endometrial window of implantation. Either it is pre-receptive or it is post-receptive, and it is associated with implantation failure. So in the patients, in about 25% of patients, it is said that this window of implantation is disturbed. So the strategies to improve endometrial function, it depends on what ovulation inducing agents we are using, what helps the endometrium to grow better. We know that injectables work better than the oral. We give anti-androgens to patients like PCOS who have got high androgen levels. We recommend lifestyle changes to get rid of their obesity and insulin resistance, which comes in the way of implantation. We follow freeze-all strategy in all conditions where we need to, especially when we want to do a pre-implantation genetic screening. There's a recent sort of concept that gut microbiota affects the vaginal microbiota, and we need to treat and assess and treat it. And the last is assessment of endometrial receptivity and the therapeutic implications. So when it comes to the molecular diagnosis of endometrial receptivity, we know that there are different subsets of transcripts in the endometrium in women with implantation failure compared to fertile controls. And hence the endometrial receptivity assay has been utilized to diagnose the personalized window of implantation so that we could switch over to a personalized embryo transfer and not the standardized day 3 or day 5 embryo transfer. Improved implantation and pregnancy rates have been reported through personalized embryo transfer. This study was carried out by Carlos Simon et al. And they looked at the effectivity of the ERA test, and they did a 5-year multicenter randomized control trial comparing the personalized embryo transfer with frozen and fresh blastocyst transfer and IVF. And in order to determine this, they enrolled 16 reproductive clinics where 458 patients less than 37 years underwent either fresh ET versus frozen ET versus PET guided frozen embryo transfer, which was preceded by ERA. If you look at their results, you'll find, look at the implantation rate. This is what I wanted to focus on. When you do a PET guided frozen embryo transfer, you get a implantation of 57.3%, with a frozen ET without personalizing it is 43.2%, which is statistically significant. And when you compare PET guided frozen embryo transfer with a fresh embryo transfer, the significance becomes highly significant. So there is definitely in this study showing that when you do a personalized embryo transfer, you are able to get a better implantation rate. The conclusion of this study was therefore that a potential utility of PET guided transfer by the ERA test at the first appointment has to be done. Of course, the disadvantage is that you have to do the ERA test in the previous cycle for you to understand because it involves taking tissue from the endometrium and assessing, and therefore you need to freeze the embryos and transfer them into the next cycle. But when this study was published, there were comments by others, and they criticized the study, saying that this trial was registered as a single blind 5-arm study and which was later changed to an unblinded 3-arm study. And only 58% women were included in the first embryo transfer, hence there were no benefits of randomization. It was unclear if the second ET was the same type as the first ET, and there was an imbalance in the number of embryo transfers per arm which was seen, and therefore this was something which was not approved of, though the jury is out there and we still don't know what's going to be the outcome finally. Now, in order to improve this endometrial asynchrony, there have been various modalities which have been tried by clinicians. It consists of intrauterine HCG transfer, intrauterine GCSF, platelet-rich plasma, giving letrozole, giving growth hormone to the stimulation protocol, adding immunomodulation, glucocorticoids, and endometrial scratch injury. Then a meta-analysis of 22 RCTs and 19 observational studies was included in this meta-analysis, where they divided all these interventions into 4 groups of therapies or intervention studies. The first group was uterine intervention, where they looked at, when hysteroscopy has been done, endometrial scratching is done, endometrial sampling is done, where atosiban treatment is given to reduce the amount of endometrial contractions during embryo transfer. And of course, they also did the lab and procedural interventions like a sequential embryo transfer, medium enriched embryo transfer, IMSI, ZIFT, assisted hatching, PGTA. The third was the immunomodulatory therapies, which consist of all these which I've talked about before, and the asynchrony identified by window of implantation through the ERA test, the using intramuscular growth hormone, vaginal sildenafil, and ERA. So putting all these 4 groups together, the conclusions of the study were that it is the intrauterine PBMC infusion or the PRP infusion and the subcutaneous GCSF which seems to be the most promising. And they gave an overall, a 2 times higher clinical pregnancy rate and live birth rate, statistically significant for PBMC and for all 3 of them. Only thing is, in these 3, only the clinical pregnancy rate was evaluated, while live birth was evaluated even for PBMC. So these seems to be the current promising therapies which may help to reduce the endometrial embryo asynchrony. Now, what is coming up next is artificial intelligence. So what is artificial intelligence? It's a duplication of human intelligence processes by machines, especially by computer systems. These processes include learning. Learning means acquisition of information, first of all, collecting it, reasoning within your brain as we reason, and we come to a self-correction. So the machine is taught to do this by putting in a whole lot of data into it so that it can learn from its own database. So it was first coined by a group of researchers in 1995, and since then applications have been used in daily lives. For example, you have the automated vehicles today where you don't really need a driver to drive. The car drives on its own, parks on its own. There's facial recognition on phones. There's intelligent voice assistants like Siri, which is used on an iPad or an iPhone, and by just speaking to Siri, you can get the information you're looking for. You can also track a parcel when it goes through a Blue Dart service. You can also call an Uber taxi and know where exactly it is. You can call your lab and find out where your technician has reached. You can use it in medicine where a 24-hour Holter test is done. Initially, the Holter test included going to the hospital, getting a gadget fitted on you, going home, waiting for 24 hours, and going back to the doctor for interpretation. But now through Apple Watch, it is possible to email your results to the doctor, and the computer in the watch makes a diagnosis, tells the patient whether the patient needs to go to the hospital or not to go to the hospital. So similarly, these applications have been used in healthcare. It's already being used in oncology, radiology, cardiology, where all these technologies have been used, and then screening takes place, and the ones which are little borderline or looking abnormal are then looked at by the specialist. The application was initiated in assisted reproductive technology in the late 90s, and they have created algorithms predicting whether this person, what would be the outcome of that particular IVF cycle. The algorithms have also been used for sperm cell classification and for oocyte and embryo selection. So there's an immense ongoing research today on the embryo and the endometrium. AI will assist in selecting the best embryo to implant and when best to transfer it. And hopefully we may be able to offer 100% success to our couples. The current pregnancy rate is about 4.5% per oocyte retrieved. And this assessment is based on what the embryologist sees on morphology and how it develops further, whether it gets fertilized, whether it grows further. The third thing is there are new non-invasive biomarkers which we need, maybe from the culture medium, to know whether the embryo is likely to be growing better, is better for success rates. And therefore today AI algorithms have been created which seem promising to assess oocytes from the GV stage to the metaphase 2 through time lapse and gene expression. Now this assessment of oocytes could be possible in which they have calculated the cytoplasmic movement velocity. And in 91% patients, they have found that there's extreme amount of accuracy through ART neural networks. This is also a kind of artificial intelligence, which is more like a 3D visualization of the egg, and it is called deep learning. We can also measure the viscoelastic properties of the human zygotes hours after fertilization, and this is with more than 90% precision. Human eggs are supposed to radiate zinc when they are injected with sperm enzyme, and the first visible sign that an egg is fertilized is the newly discovered human zinc spark. Zinc is visualized outside the human egg as a radiating burst of metal bound to probes that make the zinc visible. And once you see that zinc, you know that the sperm has entered into the egg because it carries the sperm enzyme. Now, researchers from Northwestern University are studying these sparks, and hopefully we should get some good results very soon. The goal is to develop a device which can detect these zinc sparks as fluorescent sparks in a way that embryologists can see this and detect the most promising fertilized eggs which they need to transfer. AI also helps in sperm selection by morphology and kinetics. It helps to determine the morphology and also how it's moving. It helps to diagnose abnormal sperms and also helps to assess the quality of the sperm based on other factors like testicular volume, FSH, LH, total testosterone, and the ejaculate volume with almost a 95% accuracy. Now, when we do a PGS or a pre-implantation genetic screening, it's an invasive procedure where you take a biopsy from the embryo. These photographed embryos that recognize these subtle textures are not really visible to the human eye. And therefore, with artificial intelligence, we would be able to assess the metabolism and the DNA damage in these embryos. Stanford researchers are focusing on the squishiness of an embryo, so that when you squish an embryo, the resistance to that slight squeeze from a pipette will help to predict which embryo has a higher chance of implantation. This will help to predict 90% of the times as to which embryo will reach the blastocyst stage. Now, the current embryo assessment is subjective based on morphology, etc. But today, with the help of AI, we are able to identify abnormal embryos, and we are also able to grade and quantify the inner cell mass and trophectoderm quality. We can also assess the quality and grading of embryos and assess quality and normality. Mitochondrial DNA has been measured in the blastocysts which are to be implanted, and these mitochondrial DNA help. If there is more than a threshold amount of DNA present, then they are likely not to implant. And therefore, based on the amount of DNA levels in the blastocyst, they are able to decide which blastocyst to implant. Now, all this unreliable production of results which occurs when embryologists are looking at embryo quality, with whatever best embryologist you may find, you still feel that you are not at 100% success rate. And this study has been done using STORC as a methodology, which is an AI developed methodology, which helps to predict very well the blastocyst quality. So this was a study which was carried out where they were comparing 2,182 embryos, and they were comparing the quality with integrating the patient's age to predict IVF outcome. They compared it in patients with different modalities, and what really they did was they looked at embryos, and if you see this embryo here, this has been detected poor by the embryologist, but this has been detected a good quality by the artificial intelligence, and this gave a successful pregnancy rate. Similarly, the embryologist said this is not a good embryo, and the artificial intelligence, the STORC, said this is good, and this gave us said it is poor, and therefore, good, and therefore it gave a good result. So in short, we need to assess that, and this study where they compared 5 embryologists compared to the STORC analysis, and they found that these yellow bars, which are suggestive of all good quality embryos, when you see the other 5 embryologists, they give different variable results. And same thing holds for this analysis, where the dark blue bar is all poor embryos, poor quality embryos by the stock, by artificial intelligence, whilst the others are looking differently. So in short, and they've compared this to the success rates and found that AI gives you more accurate results as compared to just the clinician looking at it. And therefore, with this kind of a diagram, they are able to assess, keeping age and quality in mind, as to what are the chances of a pregnancy with a particular embryo in patients who are undergoing IVF. So the benefits are tremendous, and it will improve the efficiency of ART, it will improve subsequent pregnancy outcomes, it will improve treatment options, patient care, and it will minimize healthcare cost. Now, does that mean that the artificial intelligence will replace embryologists? No, it is not going to replace them. It will only be an auxiliary tool to assist and not replace them. The problem is that there are legal and ethical issues. If an AI identifies an abnormal embryo as normal, and you at the end and the clinician transfers it, who will it blame? Will it blame the embryologist, or will it blame the clinician or the artificial intelligence? Could the technology be misused for designing embryos with the best genes, so that the rich who can afford it can have the best genes and the poor who can't will not afford it? There are many guidelines and recommendations developed by various associations, and the Canadian Associations of Radiologists have already developed their guidelines and recommendations into place. But with ART, there's an issue, because we have to consider ethics, because we are dealing with human beings, and therefore the recommendations still need to be laid down if AI has to be used in clinical practice. So it is our perennial anxiety when we feed in telephone numbers in our mobiles, and we don't make any effort to memorize them. We switch on our mobile, look at the number and dial. When we are driving automated cars, will the drivers become less alert? I agree, they do become less alert, and there are accidents which do happen. But will the same happen to us in medicine? So we all know that technologies can only assist the embryology, and it will never replace the embryologist's skilled eye. And the use of artificial intelligence will assist embryologists in making a more accurate and a quicker diagnosis, just how clinicians have tools to help them in their diagnosis. And the power of the brain has no limit. 30 years later, we will be better at our imagination and our feelings, the gut feeling, because the routine jobs will be done by the robots, and we as human beings will work with our imagination and do much better for our patients. This Japanese millionaire SoftBank's CEO, Masayoshi Son, said, in about 30 years, AI will have an IQ of 10,000. Average IQ of a human is 100, and IQ of a genius today is 200. It's possible that machine learning will become smarter than the human brain, and it will certainly happen during this century. So in conclusion, I would like to say that there are many, many therapies which have been tried, and till today we do not know which therapy is the right therapy for the right protocol for the right patient, and hence we hope that AI, which seems very promising, will be at our rescue to give us a 100% result for our IVF patients. Thank you so much for your kind attention.
Thank you very much, Professor Shah, for making a difficult chapter, endometrial. Can you hear me? Can all of you hear me, please?
Yeah, we can hear you.
Yeah, I said that thank you very much for a wonderful talk, particularly highlighting the role of artificial intelligence in IVF, which at one time, maybe in many years, might become 100%, as you said. Frankly, we don't have much time for questions. So can I move to the second speaker, Sujata Kar, who shall be speaking on new advances in art. Dr. Sujata Kar. You can start your talk, please.
Yeah, thank you so much. I'll just share my screen. Okay, I hope it's there.
Yes, it is.
Yeah, okay. So my topic is advances in art techniques, controversies and consensus. So it's a very, very light talk. There is hardly any hardcore academics. And this is about what the current evidence says about some of the advances in art that we are actually following. Dr. Duru has shown a lot of it, but she has shown about artificial intelligence and what the future of art might hold. I am talking about what the advances that currently we have and what is the evidence. But like she said, this was the paper that showed us that sky is the limit in ART, which means a time might come. This paper by Jacques Cohen from Reprogenetics, which was published in Reproductive Biomedicine Online, they showed that if we go by the advances in art in the last 35-40 years, it is possible that by 2053, in women less than 35 years, with a single embryo transfer of euploid embryo, we might have 100% success rate. So it is actually an algorithm which some people have calculated and shown. So in my talk today, I'll be covering advances in embryo selection, about time-lapse and PGTA, advances in improving oocyte quality, clinical and lab techniques, ovarian rejuvenation techniques, polytropin delta, and if I have time, advances to assess endometrial receptivity, which Dr. Duru has covered quite a lot. Now, how to choose the best embryo? We have two techniques which are very much in clinical practice. One is a time-lapse and PGTA. Let us examine one after the other. At this time, most of us use morphological assessment of embryos, how to choose which one to transfer. Now, it would be easy if the two embryos would look like this. If one embryo looks like this, one embryo looks like this, it's very easy. We can make a call. But if two embryos are looking like this, it becomes a real challenge as to choose which one you want to transfer. Now, time-lapse imaging, which has entered the market for quite a few years, and it is there. Advantages are many. It maintains a stable culture environment. It limits exposure to light, air, movement, temperature. Morphokinetic assessment is also added to the morphologic assessment. A high-tech software is there, which can reduce observer bias and error. And it was shown by this paper that out of the 35 criteria that are used to mark morphokinetic, morphometric, and morphologic variables, only two, which is the position, pronuclei position at the time of PN juxtaposition and the absence of multinucleated blastomere at 2-cell stage, were potentially associated with live birth. So, does a costly technique like time-lapse justify the cost? Let us look at what the current literature says, because we are only interested in improving the chances of pregnancy, which is pregnancy rate, live birth rate, miscarriage rate, and stillbirth rate. These are the 4 parameters that we want to be improved in our IVF cycle. Does time-lapse help us to do that? Before I start, this is a paper that tells us that as of now, hardly 17% of labs use this technology in the United States, and I'm sure in India, the figure would be somewhere around 1% or 2%. So the last Cochrane review in 2019, which covered about 3,000 patients and covered these 4 issues that I mentioned, told us that there is very low quality evidence which has been studied out of these 3,000 patients. But when we compare time-lapse technology with the conventional assessment, time-lapse technology, both still images as well as embryo selection software, the artificial intelligence technique that they're using, all the parameters, there is no good evidence showing that time-lapse is more or less effective than conventional methods of embryo incubation and assessment. This was the Cochrane review of 2019. Now, this was another very good review that tried to study if using time-lapse can help us in selecting a euploid embryo. Can it let it go without doing a embryo aneuploidy screening. So they also reported that morphokinetic parameters cannot be used as a surrogate to PGS to determine embryoploidy in vitro. And this was the best argument and the best paper that I found to put up the points for and against time-lapse as of today. So time-lapse against the arguments are that although we should support new technology that improves patient outcome, however, reproductive medicine must be treated like any other medical specialty where it is unethical and unspecified scientific to offer treatment without robust scientific evidence of its effectiveness, clinical or financial. So in this matter, time-lapse does not seem to be fulfilling that choice. The argument for time-lapse was it is a safe, uninterrupted, constant embryo observation option that can aid in embryo selection and can be used for research purposes. Time-lapse has been thought to provide valuable data to choose the most suitable embryo for a cost-effective drop ectoderm biopsy strategy for aneuploidy screening and for single embryo transfer. So this is a good technique, and if good and potential technique are not adopted in clinical practice, then it can never prove itself. So that was the best argument for time-lapse. Now the next point was, is pre-implantation genetic testing, which is PGTA for aneuploidy screening, is this technique up to our clinical mark, like as of today? Before, of course, the next speaker, Dr. Firoza Parikh, is going to speak a lot about the academic aspect of this. I'll just show you the gross evidence that is there as of now. Before starting about PGTA, let me remind you about the black box of human reproduction. We know that about almost 60 to 70% of human embryos that are ever conceived do not see the light of the day. Just about 30% of the embryos that are ever formed in nature become live birth. So in any case, human reproduction is inherently extremely wasteful. So the common indications for PGTA are in older women, cases of recurrent implantation failure, recurrent pregnancy loss, previously affected offspring where you do PGT, single mutation gene, or you do PGTM, and severe male factor where there are higher chances of sex chromosome abnormality when you are choosing a E set, and now it is being used quite often to improve IVF outcome. How far that is justified is what we need to see. So there are various diagnostic approaches for genomics. We have the FISH, CGH array, PCR, but most modern laboratories will be using the next generation sequencing, which is not only cheap, but very accurate. And we, over the years, we have moved from day 3 blastomere biopsy, which had the major problem issues of causing possibility of higher abnormality levels in the embryos thus formed, and mosaicism and potential for embryo damage by using early blastomere biopsy. Now we have moved on to day 5, day 6 trophectoderm biopsy. But even with this biopsy, there are major issues still remaining to be solved. The issue of mosaicism and the fact that there could be failure or a loss of normal embryos when you culture them from day 3 to day 5. Mosaicism, as you all know, refers to 2 or more cells, cell population with different chromosomal complements being present within the same embryo. And this is a major confounding factor when you're using PGTA. So what does the current evidence, whether the current evidence supports PGTA, whether it is for routine use or when it is used for specific indication? I am going to quote the summary take-home message from the ASRM committee report on PGTA. So the value of PGTA as a universal screening test for all IVF patients has yet to be determined. Whether it should be routinely used for all IVF patients. Cost effectivity may be justified in a select group of recurrent implantation and recurrent pregnancy loss patients only. The extremely challenging question of false positive testing, embryonic damage, and the loss of euploid embryos between day 3 and day 5 blastulation remains unanswered. Advancement in extended embryo culture, blastocyst biopsy technique, and a 24 chromosome aneuploidy screening platforms have made this technique safe and accessible. Embryonic mosaicism is believed to be a confounder when trying to interpret the PGTA results. Improved genomic coverage of new sequencing platforms like NGS has increased the identification and diagnosis of mosaicism and partial aneuploidies in implantation embryos. Discarding mosaics may potentially result in loss of normal embryos. This area of controversy will not be solved in the near future. So like I said, our next speaker will be throwing more light on it. PGTA is definitely a technology to stay, and it definitely has certain advantage, but maybe in a select group of patients with highly technologically advanced laboratory and at good hands who are competent with embryo biopsy and all that. So the future of embryo selection is probably not only genomics, which is embryo biopsy and time lapse. We will probably have to add other methodologies like proteomics and metabolomics, which might help improve embryo selection, and of course many of the new techniques that Dr. Duru Shah showed in her slides. So the second point was, can we improve embryo oocyte quality and quantity? What is the current practice that is possible in our hands? So we know a lot about quantity. We know about the antral follicle count, we know about the AMH, and of course our best friend, the female age. We rely mostly on that to know about the embryo oocyte quantity, but we know almost nothing about oocyte quality. And here also we should be remembering that oocytes, human oocytes, again are an extremely wasteful proposition, because we know that out of the millions that a female child is endowed with, barely a few actually ovulate in their reproductive period. So is it possible to improve oocyte quality? 3 techniques I want to discuss. Coenzyme Q10 supplementation, which might sound very cliche because we do it often. There is no human studies to show that, but there are good animal studies, rat studies, which have actually shown that supplementing with coenzyme Q10 might improve the oocyte quality. But the 2 things that I wanted to talk about today, one which is very much in our hand as clinicians, novel stimulation and trigger protocols, and mitochondrial transfer. Now, autologous, the mitochondria are the powerhouse of every cell, and autologous mitochondrial transfer is a latest technology which might hold promise and which may be within our reach, because there appears to be a close relationship between mitochondrial DNA quantity in the embryo and the oocyte and the female age, embryoploidy, and implantation potential. So energizing the eggs with healthy mitochondria, is it a dream or a reality? But yes, it is very much reachable. The mitochondria can be supplemented from other somatic cells or from blastocysts that has been derived, or it can be also used autologous mitochondrial transfer, which is a technique which is done like this. You do a laparoscopy, you do ovarian biopsy and take the sample of the ovarian cortex. Some egg precursor cells are identified, isolated, and from then in the laboratory, the mitochondria are isolated and collected and kept. And then when the same patient undergoes a IVF in the lab, these mitochondria are pushed back into the oocyte. So this is autologous embryo transfer, autologous mitochondrial transfer, which has been shown to improve the oocyte quality. Now, some novel stimulation and trigger techniques have shown to have better oocyte quality. I guess it does not improve the oocyte of quality of existing oocyte, but it might at least help us in getting the best quality oocytes from the cohort that we are stimulating. So, and this, of course, we know is based on the fact that final oocyte maturation is a complex process, and it involves nuclear, cytoplasmic, epigenetic maturity. And our typical IVF cycle, in which we stimulate and then we give a trigger, may not actually be looking at all these aspects of maturity of a oocyte. So a couple of things. Number one is adding letrozole with gonadotrophins for stimulation, either throughout cycle or first 5 days, giving a double trigger and a kisspeptin trigger. So this is not for poor responder, neither this is for hyper responder. We are not talking about that category of patients. We are talking about normal responders during normal regular IVF cycles. We don't do all these things. We don't give a letrozole. We just stimulate them with gonadotrophins. We don't give a double trigger. If they are fine normal responders, we just give them a HCG, and Kisspeptin, of course, is not yet out there in the market everywhere. So the rationale for giving letrozole in every stimulation cycle is letrozole and gonadotrophins throughout the cycle, stimulation cycle, can significantly decrease estradiol concentrations as expected, but interestingly also increase the number of mature oocytes for cryopreservation. So obviously, if you give letrozole for a longer period of time, you have to have it a freeze-all cycle. But that is the rationale for doing that. The rationale for double trigger is also very interesting, because in spontaneous ovulation, we know that it is preceded by a surge of both FSH and LH, which is thought to be necessary for final oocyte maturation. So initiation of a follicular rupture. So standard IVF cycle utilize HCG as a surrogate for LH surge. In contrast to HCG, the gonadotrophin agonist induces gonadotrophin surge, mimics the natural mid-cycle surge, and exposes follicles to both LH and FSH. Now, this is a slide, a graph. This we are very aware of. This is the normal menstrual cycle. We know that this is a natural LH surge that looks like, it lasts for about 36 hours or so. Now, this is what happens when you're giving a HCG. It's far from being like a natural one. This is like a gonadotrophin, GnRH agonist. This is close to the natural, but it still does not fulfill all the criteria, because the peak is reached much sooner and the downfall is also much sooner. The LH surge, and this is using Kisspeptin, which has a lower amplitude, but this follows the natural surge much more. The another factor is that we know that HCG acts directly on the ovary to induce maturation of the follicles, luteinization of the follicles. GnRH agonist is better because it acts on the pituitary. The Kisspeptin is even better because it acts on the hypothalamus. So logically, it sounds as though a GnRH agonist trigger or a Kisspeptin trigger is probably the best, and adding both dual triggers in a normal responder might give us more mature oocytes. Now, the third was ovarian rejuvenation technique. This has gained popularity in the last decade or so, and this was because it was suggested that maybe renewable ovarian germ cell stem lines exist in adults, and the fact that such cells may be utilized as an oocyte source for women seeking to extend their fertility. This is far from reality, but yes, some research has shown that maybe we do have a fixed number of oocytes that we are born with, but there are probably hidden germ cell stem cells in the ovarian tissue, which might be made to rejuvenate much later in life. So some techniques for ovarian rejuvenation are PRP, bone marrow stem cells into the ovary, bone marrow stem cells into ovarian artery by the ultrasound guided techniques, in vitro activation, and ovarian fragmentation for follicular activation. These are some new techniques. Ovarian fragmentation for follicular activation has quite a few decent number of studies to support it. It is called in vitro activation. What is done is that in older women, you do a ovariectomy. Residual follicles are activated in vitro using a AKT stimulator, and then you follow it by another tissue autotransplantation of the ovarian tissue. So extensive procedure, but it has quite a few publications to support it. The common one which we are doing, which has gained popularity, like I mentioned, is the autologous PRP intraovarian injection, typically 6 to 8 weeks before stimulation. PRP is prepared and between 21 to 24 degrees, calcium gluconate, etc. is added. 3 to 5 ml is given injected into the ovaries. It can be used, of course, ultrasound guided, even laparoscopic guided. And various techniques that have been used, you can use bone marrows, you can use adipose derived stem cells, amniotic fluid mesenchymal stem cells, umbilical cord stem cells, human embryonic stem cells, menstrual blood, endometrial stem cells, etc. have all been used. And the techniques have, like I said, ovarian, laparoscopic, vaginal, ultrasound guided technique, perfusion into the into the ovarian artery also has been given to improve either the endometrium or the ovarian perfusion. But the current position, what does the evidence tell us? Adult stem cells from several origins, the rationale is that adult stem cells can promote follicular development by increasing ovarian local vascularization, increasing follicles numbers, stromal cell proliferation, and reduce cell apoptosis and follicular atresia. Nevertheless, further research is needed, and they need to evaluate underlying mechanisms. We have to be satisfied as to how it works and identify the best cell source for stem cells and design a less invasive infusion technique. Now, folitropin delta. This is a recombinant FSH, which has been derived from human fetal retinal cell lines. It is intended for ovarian stimulation for IVF. It is now already available in some European countries. The dosing algorithms for folitropin delta is dependent only on anti-Mullerian hormone level and the body weight of the person. So it makes individualized stimulation very easy. Like I said, this is the commercial preparation. Now, dosing is, there is an algorithm available. It is based only on the patient weight and the AMH levels. Based on that, you dose it. Currently, we use many, like you need patient age, you need to have AMH, you need to have AFC. Many people also use FSH. So you need at least these 4 or 5 variables to make your individualize your stimulation for the patient. So folitropin delta is now the recent one, and it has many recent studies have shown that we strongly recommend and encourage the use of this gonadotropin on a much larger scale. And the best part is that it can be used very much for the low risk, for lowering the risk of OHSS in hyper responders. Can we better assess endometrial receptivity? I think Madam Dr. Duru has spoken a lot of new techniques, so let me not go there. I had just gathered a little evidence, a recent publication, 2021. ERA is the one which we use so commonly, and it has picked up in at least major places in our country also. But 2021 publication in fertility, sterility, and human reproduction, the 2 top impact factor journals in reproductive medicine, this paper conclusion was there is no difference in live birth rate in patients who underwent ERA compared to those who did not undergo ERA. I don't know, you all may not agree with me, and this is not something which I'm propagating or anything against ERA, but this is the recent publication in Human Reproduction Open 2021, Endometrial Receptivity Analysis Test, and Unproven Technology. So the point is that the ERA is based on gene expression profile of the endometrium of a certain group of certain patients. The point is human genomics is extremely complicated, and it is possible that there are a lot of variabilities in different patient categories. We should have similar studies for Indian patients, and we should have what our group of patients express, which kind of gene profile, etc., and then categorize and then devise a genomic study for our patients, and that should be valid for different places differently. And it cannot be a one size fit all for all countries and all patient categories. Ultrasound assessment also has not proven very useful. There were many techniques and many publications related to 3D ultrasound volume calculation, 3D power Doppler, and 3D blood flow studies of the endometrium to assess endometrial receptivity, but they have not stood the evidence yet is not supportive. There are quite a few studies on endometrial waves in predicting receptive endometrium, the fundo-cervical and cervicofundal wave pattern, direction, frequency. Maybe this has some promise in the near future. Subendometrial endometrial wave frequency pattern and etc. might help. It might be the next future. So if I am to conclude with just one slide, then whatever new technologies become available as ART specialists, it becomes very difficult for us to choose and adapt and adopt that technology. See, for example, somebody like me, I have to really think hard whether I should buy a time lapse, spending about 1 crore of rupees, and whether it's worth it, whether the cost, whether the fact that I'll be charging more from the patient, whether it is justified. So if we have to simply say in one word, any new evidence-based procedure, whatever it is, whether it is PRP, whether it is time lapse, whether it is PGTA for normal IVF, any procedure that offers at least a 10% increase in live birth rate with respect to routine IVF for a less than 10% of the cost of a round of IVF, that should be seriously discussed with the patient and seriously considered. Thank you very much. To end, I have a nice video from a movie called Gataka. This tells us the future of ART, what the future might have, what all the techniques that Dr. Duru Shah showed, and the time might come when our IVF labs will be totally automated, taken over by AI, producing designer babies, and totally under the control of the state that we want to produce genetically superior human beings. Thank you very much.
Or a single hair. Success is determined by science. Someone else's. Congratulations. What about the interview?
Thank you.
Welcome to Gattaca.
Hi, Dr. Firoza.
Hi, Sujata. Superb talk. Loved it.
Yeah. Thank you very much, Dr. Kaur, for a superb talk, as Firoza said. And we shall keep the questions at the end of this session because of short of time. Well, I have pleasure in welcoming Firoza, a great lady in Bombay, a dear friend of mine, and whose husband is equally famous and had written a wonderful book on coronavirus when it started, and it was acclaimed all over the world. Firoza, it's my pleasure talking to you. You're most welcome to start your talk. Your talk is going to be PGT is relevance today. Firoza.
Thank you, sir. Thank you, Dr. Dasgupta, for your kind introduction. Thank you very much to the organizers, for Ratna and Dr. Gautam Kastigir for inviting me. My talk is going to be short, but if there is time for question answers, I would like to talk a little bit about yesterday's conference and the views on PGTA. There was a conference of the 4th IVF worldwide conference, and maybe if there is time, I will talk about it. Can you please start my recording? Hello, my friends. It's such a pleasure for me to be a part of ACE 2021. At the outset, I would like to thank Dr. Ratna Chattopadhyay and Dr. Gautam Kastigir for inviting me to this wonderful event. My topic is going to be on PGT, and we are going to cover many salient features which are very important when offering PGT to a patient. The first slide, this slide shows you that the rate of aneuploidy increases as the woman's age increases. So around the age of 45, more than 90% of the embryos will be abnormal. Therefore, it is important to decide which woman is going to need PGT. Now, this is just a slide to see the history of PGT. We won't go too much on it, but it started way back in 1995 when PGT was called PGD, all the way up to 2020, where it is PGT version 4, which includes non-invasive PGT. So these are some of the authors that you would like to look at their papers in order to understand all the work that has gone into this topic. I have quoted many of these. This is the other slide showing some of our Indian people also who have worked on this topic. Now, what are the aims of PGT? Why do we do PGT? One is that we hope to increase clinical pregnancy rates per embryo transfer. It is used for women with repeated miscarriages. It increases the application of single embryo transfer and reduces the time to get pregnant. It is very well used for women with advanced maternal age, repeated miscarriages, repeated implantation failure, and those with severe male factor. These are the typical indications for PGT. In this topic, we are going to look at the pros and cons, when to use PGTA, how to use, and will it be cost effective? In my opinion, it is cost effective if used in the right sense because it reduces the time to pregnancy. So it has better chances of implantation in the very first cycle. It decreases the miscarriage rate. And for women aged 40 to 45 years, more than 8,700 live births have been recorded only in Japan. So this is a paper by Saito which gives the importance of PGTA. There are many cons, and therefore one must know all the cons before one goes to the pros. The full biology of the human pre-implantation embryo is still not well understood. It is expensive, but it has its own cost-benefit ratio, and therefore there will be times when PGTA becomes important. Now, if the biopsy is not done properly, there can be embryo damage, and therefore you may get a false negative rate or a false negative call rate. And accuracy of testing is still challenging because there is the question of mosaic embryos and so-called aneuploid embryos. So please understand that 50% of blastocysts can be aneuploid in the age of 35 to 39. And as the woman's age increases, more than 90% of the blastocysts can be aneuploid. So although PGTA will increase the implantation rate in the first ET cycle, if you look and it will diminish the time to pregnancy, it may not increase the cumulative pregnancy rate. So somebody who doesn't do PGT but has multiple cycles will obviously have the same chance because in those cohort of embryos, there will be some normal embryos. Now, one thing that we must remember is PGT can cause wastage of normal embryos, and it can have a loss of approximately 20%. And this is why PGTA has gone into disfavor with some groups. So if the discarded embryos can be as high as 40%, then PGT then has its own inherent cons, and we must be aware of this. This paper by Rubio showed that PGT improved pregnancy rates, lowered miscarriage rates, and decreased the time to live birth. This is a very important paper. Please read it if you can. And look at this. What they showed is the implantation rates were higher, 52% as compared to the non-PGT group where it was 27%. But look at the more important column in the last of the live birth rate. And you will see that there is a distinct difference between the live birth rate, which was 64% in the PGTA group, and in the non-PGTA group, it was 27%. And what they also showed that the cumulative live birth rate was also higher in this group, although it did not reach significance. But if you look at the miscarriage rate, it definitely reached significance. So there are certain benefits of doing PGTA. Here again, you will see another paper by Hu and al, which shows that implantation rates are better and miscarriage rates are lower. Here, this is the SARC data, which shows that for women less than 35, there was not much benefit, but for those in 35 to 37, there was a definite benefit of doing PGT with better implantation rates. All of you must get familiar with the STAR trial, which was done by Munne and his group. This consisted of about 34 clinics and testing in 9 labs, and they had women between the ages of 25 and 40 years who had at least 2 euploid blastocysts. And the main outcome was the ongoing pregnancy rate. Now look at this. This was a multi-center trial which involved more than 600 women in this age group, and they were randomly assigned to a single frozen embryo transfer with selection either by PGT or only by morphology, and the primary outcome was the ongoing pregnancy rate. Here, if you look carefully, for women who were less than 35, the PGT did not give much benefit, 49% as compared to 53%. But it did have a benefit in the 35 to 40 years group, where with PGT-A, the ongoing pregnancy rate was 50%, whereas in the control group, which only had morphology, was 37%. But what was the important part of the study? It shows that PGT benefits women who are more than 35 and does not benefit women who are less than 35. Hence, we have to be very careful in selection of our patients. Now, this was an article on the STAR trial, and what they showed is that because of using this for younger women, this resulted in a embryo loss of euploid embryos of almost 20%. There are other studies which have shown that the loss of euploid embryos can be as high as 40%. So the conclusion was that it showed that transferring blastocysts, which were classified as euploid, brought down the live birth rate because the cumulative pregnancy rate came down. So there are many who have questioned the role of PGT, and they feel that this testing may be flawed, and there are reasons for this, which we will go on. One of the major opponents of PGT is Shah, who has done a lot of studies to show that PGT may not be beneficial to everyone. So when this study looked at so-called aneuploid or abnormal embryos, and they did a worldwide web-based study or a survey, they found that the most beneficial was those who were older, not so much for the younger group. And even when the embryos with complex multiple chromosomal abnormalities was transferred, they still produced 10% ongoing pregnancy rate. And none of these in which aneuploid embryos were transferred had any miscarriage. So that is something to pay attention to. So-called women who had no embryos which were euploid, when they transferred abnormal embryos because they had no other choice, it resulted in pregnancies. And since there were normal births, many of them were then reported and said that possibly this abnormality may be restricted, or it can be a low mosaicism, and therefore such embryos gave rise to pregnancy and live births. So now we have seen that data shows that almost 400 so-called abnormal embryos have been transferred, which have given live births. And this can be because of the threshold of mosaicism. Now, the mosaicism can be of different types. It can only affect part of the inner cell mass, or it can affect part of the trophectodome. So depending on how much mosaicism is there, there is a threshold, which is a cutoff of 40, but these are very tentative data percentages. People say less than 20 will give good results, 20 to 40% mosaicism will give moderate results, and greater than 40, you may not see results. But this also has been disproved, which I will show you in some later slides. So is there a shift? Should there be a shift in our thinking about embryo selection with PGT-A? And this is a lovely chart which you all must see. What Shah has shown that if you go on to culturing an embryo to day 5, your cumulative pregnancy rates come down. So there are some disadvantages of keeping embryos in culture till day 5. Mathematically, he has shown that 5 to 6 cells are not enough to reflect on the euploidy status of an embryo. And if you really want to know the euploidy status, you need at least 27 cells. And of course, that is not possible. We cannot biopsy 27 trophectodome cells. So what are the causes for this discrepancy? Is it the technology? Is it related to the embryo or the IVF lab? Do the culture conditions cause mitotic errors? because there are some papers which show that if the culture conditions are not good, there's a higher chance of mitotic, that is post-fertilization errors in the embryo. Or is it the method by which the biopsy and the tubing of the cells that is done? So does the biopsy cause damage? It can, if not done properly by experienced embryologists. It also depends on whether you get a negative call rate. If you take very less cells, then there's a threshold. We need at least 5 to 8 trophectoderm cells. And should then PGT-A be replaced by non-invasive testing? There is not enough scope to discuss this because of time. And sometimes the DNA may be contaminated by maternal DNA, and therefore it can give us false positive reports or false negative reports. So the errors can occur meiotic in the gametes or mitotic, that is post-fertilization, and these can cause problems with the euploidy status. Also, where you sample from. Suppose you have done a biopsy and you want to re-biopsy. You may not get the same site, and that site may turn out to be euploid, and therefore the concordance may not be enough. So in summary, PGT-A improves the implantation rates per transfer, but does not really increase the cumulative pregnancy rates. Retesting of embryos may not give you the full concordance, and the important part is the IVF lab, the culture conditions, the way the biopsy has been done. So PGT is a tool, it's a test, and it depends on the user. But does that mean that we should not use it? No. Every patient deserves to have the technology explained, and every embryo is sacred. Of course, it is the patient's decision in the end whether she wants to carry out the process. Always, whenever you are thinking of doing PGT, remember it is your goal to give the patient a healthy live birth. That is our goal. And discuss this with all patients, because every patient needs your attention. Yes, there is a cost, but I think it is cost effective. And in the long run, you wind up doing less number of cycles, and that is where you see the cost benefit ratio. Topic of mosaicism needs to be discussed slightly. And there are studies which have shown that ongoing pregnancy rates are good even in mosaic embryos which are less than 50% mosaicism. And even mosaicism of greater than 50% gives about 15% ongoing pregnancy rates, and term pregnancy 46% in euploid, 40% in mosaicism less than 50%, and if more than 50% mosaicism, still there are pregnancies of about 15%. When you are faced with no normal embryo, there is the PGDIS and the Cogen criteria. So, sorry, this is for mosaicism. What they say is that low risk mosaics are less than 40%, high risk are greater than 40%. And within that also they have criteria that if there are mosaics, which embryos one should transfer first. So you get a live born viable baby. So this is a chart which you should keep in front of you when you are treating patients who have mosaicism. Now, if there are aneuploid embryos, then what do you do? So again, there is a chart where there is aneuploidy with mosaicism. What is the priority? So please look at this. Is a similar chart to the first one. Those which have mosaicism with the X and the Y chromosome are best avoided, particularly with the X chromosome. So to test or not to test, I think it is important to decide very carefully. Those with high maternal age, those with repeated implantation failures, those with miscarriages, and those with severe male factor should be tested. This is a summary of the whole topic. Anybody wanting more information, you're welcome to contact me on my mobile number or my email, which is frparekh@gmail.com. I will be happy to chat with you all. I'm the editor of the scientific journal Fertility and Sterility Indian edition, which is available on this site free of cost to you. And reading it can give you a lot of information on very relevant current topics. And therefore, I urge the postgraduates to go through this because it is completely free of cost. I hope I've been able to summarize my talk And I thank you very much for your patient hearing.
You made the subject look very easy. Having said that, I understand that there are no questions in the chat box, showing that three of you spoke so well that nobody had any questions. Having said that, could I ask each speaker one question so that you feel justified that we have at least got a question?
Sir,
Feroza,
I've got another talk to attend. So may you ask, can you please ask me
yeah,
first?
Feroza, yeah. See, normally you said that we need more than 5 to 8 blastocysts for doing a PGT. Now, to get 5 to 8 blastocysts in a patient who is more than 35, 40 years is not very common, number one. Number two, since the chances of spoiling embryo by doing a PGT is quite high, does it depend on the experience of the embryologist, or do you think that there are other reasons where you can reduce the chance of spoiling a biopsy?
So very good question, sir. Yes, PGT training has a long curve. We have been doing it for more than 20 years now. We nowadays don't see any damage to embryos. Also, when you're using the laser, you are doing it in a way that the pulses are directed away from the inner cell mass and are only attended on the trophectoderm cells. 5 to 8 trophectoderm cells are enough to not to give a false negative rate. So our negative call rate is almost zero. Sometimes if the tubing is not done well, if the lab has mechanical problems, then you may get a negative call rate. We have 6 embryologists who are all completely trained in doing the PGTA. We don't only do PGTA, we do PGT-M with haplotyping, we do PGT-SR. So all these things are done in our lab, sir.
Thank you very, very much. Now you can go now to your next session. It was a pleasure talking to you.
Thank you, Duru. Thank you, sir. Thank you, Sujata.
Thank you, Firuza.
Bye-bye.
Sujata, sorry, Dr. Duru Shah, Dr. Duru Shah, a small question to you. What are the patients that you advise PRP infusion? Do you do it in all patients or you select your own patients? Or you are not there? Are you there, Dr. Duru Shah? Okay, then Sujata, can you answer this question, please?
So PRP, in my practice, I have used it only for improving the thickness of the endometrium. I have not yet used it. I have not yet used it for ovary. But
Okay.
for Asherman's adhesions, if I've done an adhesiolysis, or somebody who's not having adequate endometrium, then I have used PRP.
And you got better clinical results?
Yes,
Okay.
I think so. Although I don't have a clear-cut analysis with
I
me,
understand.
but yes, I have felt that it is improved.
Okay, thank you very much to all the speakers for such wonderful talk you gave.
Thank you.
Thanks the organizers for giving me a chance to be a chairman. Thank you, everybody.
Thank you very much. Bye-bye.
Thank you, sir. Thank you, ma'am.
Varun? Hello?
Yes, ma'am.
I think I'm free henceforth, no? Because there'll be a common hall,
Yeah.
isn't
Now we have started the oration in hall D, which is happening in all the halls. So it lasts for 60 minutes. So, so around 3:45 we have to start the another session, 3 papers. It will be late. And also I have tried contacting Dr. R.B. Agarwal and Kalidas Bakshi. They are not taking my call. And can you hear me?
Yes, will that be in hall D? Hello?
Yes, ma'am. There is a free paper session.
Yes.
Paper 6. So we'll be starting late because the orientation.
Tell me the hall number.
Hall D. Ma'am, Hall D. Hello. Yes, ma'am. Hall D. Hello.
Hello, it's showing a common bar.
Yeah, I'll
just find out.
Hello. Yes. Yes.
Dr. Ratna, can you hear me? Good afternoon, ma'am. Hello, can you hear me, ma'am?
Yes, yes.
Yes. Actually, we have there is the orientation going on in Hall A, so that will finish at 2:45. So then after that session, we'll start the session here of free paper 6. We'll have to wait till 2:45.
Okay, thank you.
Dr. Kalidas Bakshi has also joined. Dr. And we have 3 students, Dr. Shinjoy Chakrabarti, Ansi Maria, Shamim Hussain. They will also join at 2:45.
Hello, Varun. Hello? Varun, are you there? Hello?
Let me see who all have come. Sharmi.
Whether ready for this session? It started now. Hello?
Yes. I'll give you the countdown of 5. Then we'll start.
Okay.
Hello, good afternoon, ma'am.
Good afternoon.
Now I'll give you a countdown of 5. 5, 4, 3, 2, 1.
Okay, I'll just share my screen. Just a moment. Should I start?
Yeah. First of all, I will. This is your ma'am.
Yes.
This is Dr. Srinjoy CV. So you can introduce him. He's giving a free paper on.
Okay. Very good afternoon. I'd like to thank the organizer of the conference for good afternoon. Very good afternoon. I would like to thank the organizer of this conference for giving me the chance for this session. I would like to introduce Sanjay Chakraborty, Srinjoy Chakraborty. He specializes in molecular biology, microbiology, cell biology, proteomics, currently working as a DRF at the Institute of Physiology and Allied Sciences at University, Scotland. In Uttar Pradesh, his work is a junior research fellow at the Institute of Physiology and Allied Sciences, Noida. His project title is the isolation and characterization of the receptor of sperm motility stimulating protein from sperm membrane and finding its role and mechanism in fertility management. Associate Academic Editor, Life Science and Medicine, is Crimson Interactive Private Limited, Mumbai. Is a project trainee in Food Technology Division, Bhabha Atomic Research Center, Mumbai. Project title is the functional characterization of M1 metalloprotease from D. inocuous radiodurans and its mutants. Research trainee, Chemotherapy Department, Apkai Institute, Mumbai. His academic achievements are qualified CSIR, NET exam and obtained lectureship. His rank is 40, qualified 14th and 15th state level microbiology organized by R.C. Patel, SCS College, Sirpur. Here he has many publications. Now I'm going to invite for his presenting the free papers. The topic is demystifying the role of calcium in regulating sperm motility. Yeah.
All right, so can I just share my screen? Just a moment. Is my screen visible? Can you just confirm? Yes. All right. So good afternoon, everyone, and thank you to all the organizers of ACE 2021 for giving me this opportunity and platform to present my work over here. And thank you to the respected chairperson for hosting this session and giving me this opportunity again. So I am Srinjoy Chakraborty. I'm a junior research fellow at the Amity Institute of Physiology and Allied Sciences. And I work under the guidance of Dr. Sudipto Shah, who is an assistant professor at Amity Institute of Physiology and Allied Sciences. We are currently working on, we've worked on developing a new laboratory, which deals with the molecular reproductive physiology of the sperm cell mostly. And in this topic or talk, I will present my literature review, which I have done which will be useful in my work here. And we are primarily a sperm biology lab over here. We are studying the importance of motility, especially, we deal with goat sperm cells because right now goat sperm cells are readily available in local slaughterhouses. So we don't need ethical clearance for that right now. But we'll be continuing our work and getting ethical clearances to start human studies as well eventually. So in this topic today, what I'm going to talk about is the importance of sperm motility and its biochemical basis. So these are the contents that I'll be covering, and mostly I'll be focusing on calcium ions. So calcium ions, which are very important secondary messengers that actually regulate several key metabolic processes in the sperm cell. So male infertility is actually a really big issue, and it has been, according to the World Health Organization, it has been defined as a disease of the reproductive system, wherein there is a failure to achieve clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. About 8 to 12% of couples actually face problems associated with infertility. And from that, about 50% of them are associated with or are contributed by male factor infertility. These are the basic sperm parameters that are usually checked when semen is analyzed. However, if there is an error, if there is a problem in the sperm parameters, that's where what we are trying to study, what are causing these errors. So most common causes of male infertility: low sperm production, abnormal sperm production, and the biochemical alterations that affect sperm transport. The clinical diagnosis usually are as follows. That is, they are either diagnosed as idiopathic male infertility, they're diagnosed as oligospermia, which is low sperm concentration, or azoospermia, which is the absence of motile sperm cells. Now, we are mostly focused on idiopathic male infertility and also studying the azoospermia, or the absence of motile cells. Now, on your screen right now, we can see that there are these various factors that actually lead to male infertility, which we all know about. But the key aspects over here, which we will also be studying, is the dietary and the lifestyle trends of a person that actually affect male infertility, which can contribute to male infertility. Especially when I talk about, as I said, I'll be talking about calcium and the dietary calcium, association of dietary calcium with the regulation of motility of cells and the maturation of sperm cells as well. Now, these are the various pathways and regulatory mechanisms that are involved in sperm motility. So as you can see over here, calcium actually plays a very important role. So there are various channels, especially the cat-spur channels, which are responsible for the influx of calcium ions, which then are metabolized, or rather which then participate with the soluble adenylyl cyclase enzymes, and which are responsible for production of CAMP, which in turn is very important in the production of energy, and it forms the basic metabolic background of how a sperm cell utilizes these particular ions, converts it in a form of energy, and we see the phenotype of motility. The protein kinase A and the serine tyrosine phosphatase is also very important. They play a very important part in sperm motility, but we are mostly focused on how calcium ions are transported inside the cell by the various cell membranes or other cell membrane proteins or channels, and also the internal Ca2+ stores. Now, calcium is a magic molecule. Calcium is a very, very important and significant element, but it's also a very, very important intracellular messenger. We know that it plays a very important role in spermatogenesis, in sperm motility, capacitation, acrosome reaction, and fertilization. Now, the role of calcium deficiency on sperm function and male fertility have been studied widely, but the mechanisms of how these abnormalities occur, the biochemical signaling, transductions, etc., are actually still under a lot of review. And especially we are going to be studying this in our future studies. Calcium deficiency over here, as we know, calcium deficiency is known to cause abnormal sperm motility, or rather we see in motile sperms or other, it is known to cause, impaired motility in sperm cells. It impairs chemotaxis. It also affects or negatively affects capacitation and the acrosomal reaction, which are, as you know, very important parts or other very important processes during the fertilization. So, on the basis of this, we know that an optimal seminal calcium concentration is absolutely essential to strengthen sperm function, which will then lead to successful fertilization. Now, the cellular and molecular mechanisms of how calcium deficiency affects this has to be properly studied, which we will be focusing on. As we know, calcium ions, as I said, they absolutely go and affect capacitation. They directly affect ATP production, which in turn affects motility. They affect steroidogenesis. So this is a flow chart describing how calcium affects the various processes of the sperm cell. Now, there are also, calcium ions, the regulation of calcium ions also depends on the nutritional aspect. So we know that calcium is actually a very important component in our diet as well. So how diet controls the entire maturation process of the spermatozoa, and how it controls the, not just the maturation process, but also we know that the sperm cell is actually, there is a very specific microenvironment around the sperm cell, which actually helps or enables the sperm to kind of perform its function. All right. So there are various nutritional aspects also to it, which need to be studied. This is a very complicated slide right here, but these are the various biochemical pathways that wherein we want to study like how the calcium ions are interacting with the various downstream processes. Once the calcium ions enter through the membrane channels, how are they kind of regulating the entire phenotype of motility? So what we know right now is that the calcium ions enter the sperm cells. They are directly interacting with the soluble adenylyl cyclase, which in turn is responsible for the conversion of ATP to CAMP. Now, CAMP directly goes and interacts with the in the protein kinase A or the PK pathways, which then in turn regulate flagellar beating, also hyperactivation, and the acrosomal reaction. Now, there is a very complex crosstalk between the cell and its vicinity or the microenvironment as the sperm cell is maturing in the epididymis, which is what we will try to kind of decipher in our future studies. But this is the background of how we have come into this conclusion. Now, as we know, we saw that the calcium ions actually play a very important role, but there is a paradox. The paradox is that the calcium ions actually show a biphasic role. Too much of calcium ions, not very good for the sperm cell. Too little of calcium ions, not very good for the sperm cell. So in the epididymis, as we know, calcium ions actually stimulate immature sperm cells. Okay, whereas in ejaculated semen, calcium ions actually inhibit sperm motility. In the concentration obviously matters. So there is a study that was performed wherein it was observed that the optimal concentration of calcium is absolutely essential. All right, so this is a study by Bhomik et al., where they saw that at about 10 micromoles, the forward motility of the sperm cells was optimal. Whereas as and how you increase the calcium concentration, the motile cells, the number of motile cells decrease. Also, it was observed that even with the treatment of EGTA showed similar kind of results. This is actually a very important paradox. Now, how is this important? I'll when we actually treat sperm cells for the proper in ART, whenever we want to treat sperm cells, also during the freeze thaw process, this in the media actually matters a lot. So any variation in this particular microenvironment of the cell is actually very critical. So what we know right now is basically that sperm cells, as we know, they are exposed to very complex microenvironment in the epididymis and also when it is outside the body. Any variation in the net water, sodium, chloride, or the bicarbonate ions actually affect the calcium resorption and expulsion, which then actually regulates a lot of these sperm behavior. Calcium exhibits a biphasic role in regulating motility, which was studied and which is now properly understood, but the biochemical signaling is still very unclear. The maturation process over here, I'm constantly emphasizing on the maturation process because that is when the sperm cells are practically trained as to understanding what is the optimum concentration of calcium and how the entire sperm cell is actually behaving. So the maturation process has to be understood properly. And this is what we are going to be doing, understand how calcium is metabolized during the various steps of sperm maturation, understand the metabolism of dietary calcium, also how if it influences the motility of the sperm cell, and also all the signaling events in the sperm cell by supplementation of the dietary calcium. Lastly, freeze thawing, as I said, freeze thawing and prolonged storage of semen samples, it plays a very critical role. So calcium ions and calcium chelators, the use should be properly regulated. So which forms the basis of this entire study. These are some of my key references, and thank you. I'm sorry, ma'am, I can't hear you.
Thank you, Sanjay, for your nice presentation. As you have nicely elaborated the role of that calcium in regulating sperm motility. Have you told that in the epidemic, the calcium ion stimulate immature sperm, and in the ejaculated sperm, calcium ion inhibits sperm motility. So, what is its role in acrosome reaction?
So in the acrosomal reaction also, as you know, that there is a lot of energy metabolism being, because there is the acrosome literally has to kind of, split open, and there's a lot of complex enzymatic processes happening. So it plays a very important role in the energetics of the cell. So as we know, ATP, the CAMP molecule or the ATP to CAMP conversion is very important. So the sperm cell demands a lot of energy during that process. Yep. So calcium ions actually play a very crucial role there. And also certain, I'm sorry, I'm just taking a little bit more of time, but how I've read more literature, in fact, calcium, there are certain proteins that are actually multi-domain proteins that actually work on identifying certain receptors on the ovum as well, which is also kind of enabled or other, which is assisted by the calcium ions in some places, which now they are kind of studying this, especially with respect to certain specific antigens, which are called cancer testis antigen, which are now the huge topic. So over here also, there are some receptor proteins that are actually regulated by certain calcium molecules. So in acrosomal reaction, I would say the energetics plays a very important role. So calcium, that's there.
It trigger acrosome reaction and facilitate the sperm to penetrate into ova, no?
Yes.
Yes.
Yes, and also the hyperactivation before.
Yes.
Because only when the sperm
it requires hyperactivation also during capacitation also, no?
Capacitation
in vivo. It is in vivo.
Yes,
but in vitro, how it is acquired that capacitation process?
This now has to be like my entire basis is in the in vivo model. So in vitro model, I will have to read about it, but I think mimicking what is there in the in vivo model is where I think is what I understand from. So because That's the thing.
There are other also in the sperm preparation techniques there.
Yes.
And
Yes.
calcium media and all.
Yes.
There factors are there which can
Yes.
show
Yes.
it occurs, the
Yes,
capacitor
ma'am.
occurs.
Yes. So I will be learning in
Thank
vitro
you for your
fertilization
nice
right now.
presentation.
So hopefully I'll gain some expertise
Okay,
on
you
it right now.
Okay, sure.
So,
Sure,
all right.
sure.
Thank you so much, ma'am. Please take care. Yeah. I'll stop sharing my screen.
I'd like to invite the second speaker of the session. Is the second, is there NC Maria woman?
Yes, ma'am. I'm here.
Okay. She's a senior embryologist at RC International Fertility Center, Tamil Nadu, in 2019. Since 2019, embryologist at Yana IVF Center, Kerala, 2018 to 2019. Embryologist at JJ IVF Center, Kerala, 2018. Junior embryologist at Kraft Hospital and Research Center, Kerala, 2012 to 2015. Yeah, over to Ansi Maria, who is going to talk on the topic, effect of pandemic induced stress on semen quality. Okay, over to.
Okay, ma'am. Am I audible? My screen is visible, ma'am? Okay, okay.
Yes, okay, right. You can start.
Okay, thank you, ma'am, for the introduction. I'm really honored to get introduced by you. And thank you. First of all, thank you, Ace, for giving me this platform. My topic is effect of pandemic-induced stress on semen quality. So as we all know, male infertility is a widespread condition among couples, and the key indicator of this is the semen quality. And in the contemporary situation, we all know that stress has become a prominent part of our society. There are previous studies which suggest that there is a reasonable association between social, psychological, or psychosocial stress and the reproductive health of man. Even the complete mechanism is unknown. Some researchers says that the stress releases the steroid hormones like glucocorticoids, which reduces LH and testosterone, thus in turn reducing spermatogenesis and sperm quality. And we know that this COVID-19 pandemic and lockdown, which has brought about a sense of fear and anxiety around the globe. And this phenomenon has led to a short-term as well as long-term psychological and mental health implications, such as being economically unprivileged, being quarantined due to infection or due to fear of infection. In this, our small study aimed to compare the semen parameters, vital semen parameters, such as concentration, motility, and morphology before and after COVID-19 lockdown, and analyze whether the lockdown-related stress has any impact on the same. So coming to the design, this retrospective study includes semen samples of 211 men enrolled for IVF treatment in our center. The mean age was 36.6, and the initial semen analysis was done from November 2019 to March 2020. And there was a lockdown after that. So after 10 weeks of complete shutdown, they came to the center and ejaculated for re-evaluation and cryopreservation for the treatment during the period of June to August 2020. The semen analysis assessment was done in accordance with WHO fifth line guidelines. Now we are following 6th edition, but that time it was 5th edition. The samples with complete absence of sperms, like azoospermic patients, and over there, if there is a complete absence of motility, those samples were excluded from the study. Then both data, the pre and post lockdown semen data, we could call it as group A and B respectively, that is before lockdown and after lockdown, from our fertility clinics were analyzed. And we also checked the patient for COVID-19 by RT-PCRs. All of the patients came negative. And also we have done a small stress level assessment manually in all men in the study group, like the stress related to work from home, stress due to isolation or fear of fear of infection, or if there is any financial risk for them. All these questions were asked for them, and we have marked it in a low, low, moderate, average kind of level. Then the vital parameters, sperm concentration, motility, and morphology of both groups were compared using paired t-test. So the result is like the probability value, the p-value. The results were taken significant when the p-value was less than 0.05. So in our study, the motility and morphology probability value was less than 0.05, where the sperm concentration was 0.06, which was not significant. So from that statistical analysis, it could be said that there is a significant reduction in sperm motility and morphology in post-lockdown samples, whereas there were no difference in sperm concentration. So from all these things, we could conclude that there is a statistical association of sperm parameters between the groups before and after lockdown, so which could possibly suggest that the negative impact of lockdown induced stress on functional parameters of sperm. And furthermore, the assessment showed moderate to high level of stress, high scores of stress level in the man. And when come to the limitations, we haven't included clinical relevant things such as age, sedentary lifestyle, BMI levels. All those are not checked in the study. And also in the future, if we do the reassessment of semen quality in the same group of men, and which may provide a further evidence of stress-induced sperm damage. At the same time, the ability of pre-pandemic and post-quarantine sperms to fertilize and ovulate and their relation to IVF outcome may offer an improved pathway of male fertility evaluation. So my sincere thanks to our dear lab director, Mrs. Agna Devi Shivananda, for her support and help, and also our MD sir and ma'am. Last but not least, Ms. Evangeline, statistician, for ruling out the statistical data. Thank you all for the patient hearing.
Thank you, NC Maria, for your nice presentation on effect of pandemic introduced stress in semen quality. Yes,
Yes,
it's a very important topic because stress also may cause very important affect the sperm quality also.
Ma'am, sorry, ma'am, I can't hear you. Voice is like voices.
Yeah, the sperm stress can decrease sperm quality also, which you have presented here. And during pandemic, pandemic, that you have analyzed so many patients' sperm analysis, and you have presented this data, and this is very important. One question is that this due to stress, there is any ROS also, oxidative stress also, it can affect and increase oxidative stress and ROS.
Yeah, it could be, ma'am, but unfortunately we couldn't include that ROS this thing. We haven't measured it. I forgot to mention it in the limitation. Yeah, it's a small study. It could be, ma'am. ROS also stress can cause reactive oxygen.
Yeah, can also
so
increase
in future
stress and also ROS level. So that it can affect ultimately it can affect sperm motility and sperm
morphology, right? Right. In future, if I get a chance, definitely I will do it. Thank you, ma'am. Thank you so much.
Thank you. Thank you for a nice presentation.
Thank you, ma'am.
I would like to invite the last speaker of this session. Who is the last speaker? Please share the slide. I think Sarmin Hussain, which is going to talk on the topic interpretation of basic semen analysis of husbands of infertile couples to observe the effect of occupation and age. Please share the slide. Hello.
Good afternoon, ma'am.
Yeah. Please share the CV of Sarmin Hussain.
Hi, everybody.
Hello.
I'm Dr. Sharmin Hussain from Bangladesh.
Okay.
I work as a clinical embryologist at Fertility Center, Combined Military Hospital, Dhaka, and also as Associate Professor of Anatomy at Armed Forces Medical College. My today's topic is interpretation of basic semen analysis of male partners of infertile couples to observe the effects of occupation and age.
Yeah, please start.
We all know that male independently contributes to infertility solely in about 25 to 30% of cases, and in combination 35 to 40% or sometimes 50% overall. The patriarchal conservative society keeps male usually away from hospital. Blame goes to female partners blindly in most cases. For diagnosis and treatment of male infertility, the semen analysis has become the cornerstone of all the workup. Worldwide, infertility practitioners rely on the results of semen analysis for the diagnosis of male factor infertility in more than 90% of cases. A very simple, cheap, easily available, and non-invasive approach has made this routine examination the most important tool for diagnosis of male infertility. In fact, male infertility cannot be determined always basing solely on a routine semen analysis. A wide range of heterogeneity is very common in human semen profile in evaluation of both macroscopic and microscopic parameters. Consistency in laboratory procedures and reporting of routine semen analysis to male infertility investigation is ensured by World Health Organization or WHO, and they published at 1980, 87, 92, 99, 2010, and very recently in 2021. The objectives of this study was to determine the percentage of abnormality in semen parameters present in the male partners of infertile couples of Bangladesh, effect of occupation on abnormal parameters, and the effect of increasing age on semen quality. This study was a cross-sectional retrospective one and conducted over the period of April 2019 to March 2020. The sample size was 372, and among 851 couples, these 372 were excluded from female cause. All of them failed to conceive even after unprotected intercourse for more than 12 months. Sexual abstinence was maintained within 2 to 7 days. And systemic examination and local examination were done. Sample was collected by masturbation into clean, sterile, wide-mouth, metal-free, non-toxic plastic jar in a room close to andrology laboratory. pH, odor, semen, viscosity, sperm concentration, total count, percentage of total motility, vitality, morphology of spermatozoa were assessed. Sperm were counted using numerous hemocytometer. Sperm motility was assessed as categories of progressive, non-progressive, and immotile sperms, and total motility was calculated. A sperm morphology was assessed using air-dried semen smears, fixed and stained with Papanicula stain. Statistical analysis was done by using SPSS version 23. ANOVA, chi-square test, and correlations were done. After the study, the results showed that 56% of reported husbands were normozoospermic, and 44% of them had at least one abnormality of semen parameters or combination of more of them. Out of these 44%, 3.8% had definite cause like azoospermia, 15% asthenospermia, 18% had as oligoasthenozoospermia and 8% had oligoasthenoteratozospermia. This study shows the semen status in different occupational groups. This table is showing that of the military personnel, about 58% were normozoospermic. And most of the abnormalities were mostly in the civil personnel. About 53% of the civil personnel had any of the problems in their semen parameters. So it was seen that more abnormality were in the civil counterpart. Relation of semen status and parameters in different occupational groups is shown here. This table is showing the relation of the semen status with volume, total count, total motility, and they were compared with occupational groups, and all the tests showed significant result for volume count and total motility, but no significant result we got for morphology. Mean value of semen parameters according to different age groups are grouped here. We divided the subjects into 5 age groups at interval of 5 years. It will be better if we could divide into 10 years interval, but we couldn't do that due to our small sample size. This table is showing that most of the parameters are decreasing with age, like volume, concentration, and total motility, except morphology is showing some different figures. This table is showing the range of the subjects we tested, that is the volume of semen ranged from 5 to 10, as we had some azoospermic patients, so total count 0 to 900, motility like that up to 85% for morphology. The azoospermic patients were discarded, so it was from 2 to 42%. And here the WHO cutoff value is shown for each parameter, and the subjects below the WHO cutoff value were compared. And the chi-square test showed that subjects below the cutoff value of WHO among the age groups were found to be significant for the total count and total motility, but not significant for volume and morphology. This test was also done for occupational groups, but showed no significant difference. Pearson's correlation test of these parameters with the age group were also done, and it showed significant negative correlation between age and volume, age and total count, and age and total motility. These are the diagrams for the Pearson correlation test. And we can summarize that male infertility still is a tip of iceberg due to social trend. But the study tried to focus on how much the Bangladeshi male persons are contributing to the cause of infertility. And it revealed that it is 44%. But more study is required because the sample size was very small. Degree of abnormalities were less in military personnel. Increasing age affects semen quality, and gradual decrease in semen volume with age. Much decrease in concentration after 35 years of age, and marked decrease in motility occurred after 40 years of age. This is all about the study, and thank you very much for patient hearing.
Thank you, Sarmin Hussain, for your nice presentation. As the male age increases, chances of fertility decreases. Also, But one question is that up to what age the male patient can be best age for fertile? What is the best age?
Ma'am, for this study, we have seen that about 36 is the average age, and around this age we get most fertility, ma'am.
Okay, because there are many studies also that as age increases, the quality of the sperm decreases. So the chances of fertility also decreases. Okay. But you have this studied research in your only Bangladesh only or general population?
Bangladesh only, ma'am.
Bangladesh only. Okay. 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 Thank you for your nice presentation.
Thank you, ma'am. Thank you to ACE authority for allowing me. Thank you very much, ma'am.
Thank you all the very speakers for your nice presentation on the male infertility. Thank you all.
Thank you, ma'am.
Thank you, ma'am. Thank you, everyone.